Is Dr. Sai available?
I don't think Sai has reached.
Okay. So then let us start the proceedings. Good evening, everybody. Good evening to the series of webinars of KSOS. And as a positive outcome of COVID, we have learned to pursue the distance learning option for updating our knowledge, and KSOS has mastered it to perfection. We have done one Drishti online, excellent 2 Drishtis online. And now Srini and his team has been doing this webinar series of webinars on different topics last year, and is continuing in this year also, bringing together the best of faculty to handle almost all the subspecialties of ophthalmology. And today we have the best of retina people in India and our Kerala to discuss retina in a concise manner in the next 4 hours. And it will be coordinated by our incoming president of KSOS, Dr. Thomas Cherian. The Cochin Ophthalmic Club is proud to associate with KSOS in bringing the best of scientific material to its members. And I thank KSOS for giving us an opportunity to host this webinar, and congratulate the entire COC team and the KSOS team, and wish you all a very fruitful evening. Thank you. I hand over the proceedings to Dr. Thomas Cherian, who will be moderating this session.
Thank you, Dr. Shashikumar. It is our privilege to have the 16th edition of the KSOS Scientific Committee CME series module today. And we have titled it Retina in a Capsule. This capsule has 4 parts. First session is on imaging from 5 o'clock. Each session is of 1 hour duration. From 5 to 6, we have imaging. The session will be chaired by Dr. Shane Matthew and moderated by Dr. Sindhu, followed by a session on medical retina, the third on vitreoretinal surgery, and 4th will be on uveitis. So our plan is like, we have 3 talks in the first session. The time has been allotted, and we'll have ample time for discussion following the talks. It's up to the chairman and moderators to decide whether you want the discussion after every talk or at the end of the session. That is up to you. So over to Dr. Cherian, Shane Matthew, and Dr. Sindhu for conducting the first session. Shane, please unmute yourself.
Yeah. Hello, good evening, Dr. Sindhu.
Hello, sir. Good evening, all of you. So today the first session is on retina imaging. We have got 3 eminent speakers for this session. And we all know that for decades, angiography has been the gold standard for retinal and choroidal vascular pathologies. But now with the advent of OCT angiography, whether this is going to take over FFA, some of the questions remain unanswered. So for this, we have got Dr. Praveen Murli to discuss on why do we still die. Dr. Praveen Murli did his post-graduation in ophthalmology, followed by fellowship in vitreoretina surgery from Arvind Eye Hospital, Madurai. Thereafter which he extended his services there from 2003 to 2014. Following which, for the past 10 years, he's working for Eye Foundation and currently working as VR in charge in Eye Foundation, Kochi. Welcome, Dr. Praveen Murli, sir, for the talk.
Thank you. Is the screen visible? Yes, Praveen. Slideshow. Yeah, that's
yes.
So at the onset, I thank KSS COC for giving this opportunity, as well as Dr. Thomas sir to provide me with this topic. So my topic today is, why do people still die? So FFA and ICG is available from 1961, so almost a 50-year-old. So with new technique, the older one become obsolete. So is it still relevant? As we all know that things which are old and not updated, like our Ambassador and Nokia, do FFA and ICGs get obsolete. So the tagline is, I may be obsolete, I may be old, but I still know how to party. So the die that won't die. So basically, when we see the angiogram, they are divided into choroidal phase, the arterial phase, the AV, and the venous. The first and the foremost, what we check is the arm retina time. In young, it is around 10 to 12 seconds, and old, it's around 12 to 15 seconds. The choroidal phase is around 3 to 5 seconds earlier. Anything which is delayed beyond 30 seconds is considered significant. So this was a 50-year-old male who came to me with defective vision, right eye sudden onset. What you see is diffuse hemorrhage all throughout the fundus, even in the mid periphery and far periphery. When I go back and saw the anterior segment, what you see at the margin of the pupil, it was already dilated, but still at the margin of the pupil, you can see those new vessels. And I retrospectively checked again the IOP of this patient. The IOP was on low teens. So this is a very characteristic type for ocular ischemic syndrome. It is characterized by low flow through the ophthalmic artery. So when you do an angiogram in this patient, you find delayed filling in the choroid as well as the retinal vessel. The second most important finding is a patchy choroidal filling and visibility of leading edge of the dye. So these three things, we can come to a sure shot conclusion of ocular ischemic syndrome on angiogram. This delayed in arm retina time can be seen not only in OIS, but also in CRO and CRVO. Few things, when a patient comes to you with a normal IOP, low IOP, with an NVI or an NVA, and fundus is normal, or if you have few hemorrhages, OIS should be suspected, and you should do a angiogram to all these patients. This patient, when we went ahead and did the angiogram, MRI angiogram, so we could find almost 99% obstruction in the internal carotid artery. In CRO, in acute cases, when you do an angiogram, you may get sluggishness of the blood flow through both the arteries as well as vein. In late phases meaning when the patient present to you after a month or 2 months with poor vision, the angiogram may be completely normal. But if you go ahead and see the AV transit time, it may be grossly delayed. In around 30% of the population, we can see a ciliaretinal artery, and in CRO with good vision, or if the macula is perfused, in the angiogram in the very early phase itself, you can see the ciliaretinal artery getting perfused. In the current era, especially when we see diabetic retinopathy, the role of angiogram has decreased drastically as compared to maybe a decade or 2 decades back. So at present, one of the main indication is if patient has unexplained visual loss, you can do an angiogram. Look out for signs of macular ischemia. This can be the most common thing what you see on angiogram to say it's a macular ischemia or not, is to see whether there is notching or there are fine aneurysms at the edge of the FZ. And last but not least, not very sensitive, but enlargement of FZ can also be considered as signs of macular ischemia. One very important part of angiogram is when patient has asteroid hallosis. This is one imaging system where you can pick up lot of findings which can be missed on clinical examination as well as any other imaging modality. In case of asteroid hallosis, because of those particles there is lot of reflection. So even in fundus photography or with clinical examination, due to this reflex, we are not able to see the fundus clearly. When we do an angio, the blue light goes into the eye, and the one which comes out is the green light. And the filter there, the green filter, stops all other rays other than the green light. So you can get a good image from the retina. Other indications are like when you have doubtful ND, IRMAs, very fine NVs, you can go ahead and do an angiogram to see whether there is an NV or not, and then proceed with the management. Also in asymmetrical DRs. BRVO and CRVO, whenever you plan for an angio, you wait for 2 to 3 months. The old classification always said that whenever you have at least 10 disc area of non-perfusion in the central sign field of FFA, you classify them as ischemic CRVOs or a non-perfused CRVOs. When you come to the management of CSC, angio is very much required, especially when you want to do a focal laser. I don't think so we have any other modality where we can pick up this fine leaks. And when you do an angio, always see that you go for the very early phase where you can see the pinpoint leaks. That area you can mark it and go ahead and do the focal laser, whether it's a smokestack pattern or the ink block. In ink block also, you can go ahead and see the early phases. When we see a disc edema and to have a diagnosis of ischemic optic neuropathy, you can see the disc sectoral hypoperfusion. When you see that, you can diagnose it as a ischemic optic neuropathy. Even when we have to differentiate it from an arthritic AIOL, if you can see the early phase and if there is extreme poor filling or absent filling of the choroid, it is one of the most characteristic feature of arthritic AIOL. So this feature also can be used to differentiate between arthritic and non-arthritic AIOL. In vasculitis, peripheral area can be seen as ooze. When there is a healed vasculitis, you can go ahead and see for non-perfused area, or you can see subtle neovascularization in such. The other indication are in intraocular tumors and to evaluate other retinal vascular disorders like ROPs and sickle cell retina. A little bit on ultra wide field. So the standard field is considered as 30 degree. Wide field is around 55 degree. And when we say ultra wide field, it's more than that. So this ultra wide field has revolutionized the way we look at the peripheral vascular pathology, and it has helped in diagnosis a lot of the disease as well as in the management of them. So this is what a standard field will look like, and an extended field will give an ultra wide field appearance. So it may be helpful in guiding and seeing the CNP area and go ahead with the targeted laser treatment in case of proliferative diabetic retinopathy. A little bit on ICG. So they are the procedure. It's a procedure used to examine the choroidal blood flow and associated pathology. Because of its protein binding property, the leakage from the choriocapillary is less, and they remain in the choroid for a longer time. The most important part is they are excited by light close to infrared. Thus, the penetration to the pigment epithelium, melanin, xanthophyll pigment, also the blood layers is quite high. The image scattered is also less compared to the visible light. Hence, it is better in media opacities also. They are useful in occult CMM and particularly identifying characteristic pattern of PCV and RAPs. In PCV, ICG is the gold standard for diagnosing IPCV. It is defined as the presence of a single or multiple focal nodular hyperfluorescence arising from the choroidal circulation. May or may not be associated with a branching vascular network. So in the early phase, you can see this branching network. And in a little later stage, you can see even the mature vessels, the polyps, the small vascular network also. RAP, retinitis angiomatous proliferans, it's one of the lesions where I feel ICG is quite useful. Three main things what you can see is, the first one is the retinal anastomosis. It can be picked up in very early stage. Along with that, if you see cystoid changes and pigment PEDs, pigment epithelial detachment, these three triad you can diagnose RAP lesion very easily. On FA, they are manifested always as occult CMVM with a PED. The other useful thing is when you have a peripheral exudative hemorrhagic chorioretinopathy, you can see when you do an ICG, in 30% of the cases, you can see a branching vascular pattern, and almost 70% of the cases, you will see a polyp. RAM with hemorrhage. I feel there are very few imaging where you can pick this small ruptured retinal artery aneurysm because of the blood. Whether you do an FA or you do an OCT, these are very difficult to trace. However, this small, tiny, bright lesion can be picked up on a ICG easily. In case of choroidal hemangioma also, ICG is considered superior to FA, where in the early stage itself, you can see hyperfluorescent area. And in late phase, there is an early wash-off. And this wash-off can be compared with the surrounding choroid. And this itself, these two lesions itself can differentiate this from a METS as well as a melanoma. Just the last thing about VKH and sympathetic ophthalmia, where you can see a hyperfluorescent spot, both on FFA as well as. Thank you.
Thank you, Dr. Praveen, for the excellent talk, enumerating in detail about clinical scenarios where angiography with dye, I would say, is still useful. For the benefit of the viewers, can you please tell me one clinical scenario where you still feel this cannot be replaced? This angiography cannot be replaced with any other imaging modality.
It's a difficult thing where with the evolving technology, once we get something which we can detect a high flow or the thing, I think so OCTA may take up. But till that time, all the lesions where you have to see the flow, I think so angiography cannot be replaced.
Especially while we have to, if we have to do a laser for leaking central serous chorioretinopathy, I think we will have to definitely image that area with an angiogram with the dye. And also, it's interesting to know that any other imaging modality cannot detect leakage. Only and dye angiography can show a leakage as for the technology has developed till today. So if we need to do see leakage, yes, still we will have to do an angiogram with dye. And vasculitis, rightly mentioned, to see the peripheral capillary non-perfusion area, to do laser probably in a more targeted way, you need to still have a dye angiogram. But now wide field OCT angiograms are also coming up, which is going to show us the peripheral areas. Yet another clinical situation which I usually use is when to decide on cessation of treatment of immunomodulators in cases of vasculitis. Apart from the clinical features of resolution of vessel inflammation, I definitely repeat an angiogram to see whether there is still leakage before deciding to wean off the patient from immunomodulators, for that matter, even steroids. Thank you very much for the talk, Dr. Sindhu.
So next we have got OCT biomarkers in DME and AMD by Dr. Prakash. Dr. Prakash had done MBBS from TD Medical College, Alleppey in 1997, followed which he underwent post-graduation in MS Ophthalmology from Minto Eye Hospital, Bangalore, completed in 2002, following which fellowship in vitreoretinal surgery was done in Shankar Nethralaya, Chennai in 2009. He had also underwent fellowship in ocular immunology and uveitis from New York Eye and Ear Infirmity in 2011. He is currently the medical director and head of Retina Department, Comtrust Eye Hospital, Calicut, from 2011 onwards. Welcome, Prakash sir, for the talk.
Thank you, Dr. Sindhu, and good evening to all. And thanks to KSOS and the COC for this opportunity. So today my talk is on OCT biomarkers in AMD and DME, and I have tried to really fit it into this capsule of 12 minutes. So starting with AMD, the need for biomarkers is mainly because it's a blinding disease and we have a high variability in treatment response between the various phenotypes of AMD, like the type 1, type 2, type 3. And even if you take the same phenotype between patients, there is a variability. Then you have so many treatment models, so many anti-VEGF drugs to decide on what to give, and you have different protocols. So the challenge here is to identify optimal treatment protocol, individualize, prevent loss of vision at the same time remain cost effective. So that's where I believe the OCT and the biomarkers come in handy for us. So the understanding still not complete, but we'll try to make with current evidence and other things. Let us try to make it uh, as meaningful as possible. So start with the most important is the fluid and their compartments. We have the sub-RPE fluid, which we call as a pigment epithelial detachment. We have the sub-neurosensory retinal fluid, that is SRF, and intraretinal fluid. And we have the other structural markers on OCT, as well as the vitreoretinal interface and choroidal markers. So starting with subretinal fluid, the most important biomarker, we have seen that the visual acuity is better when it is SRF alone compared to SRF with PED, and worst situation is SRF with PED plus intraretinal fluid. Prognostically, this is the worst, and best is the SRF. And from view trial, we have seen that higher visual acuity at presentation as well as throughout the treatment course is seen with patients with only subretinal fluid without the other forms of fluid. Fluid study looked at what main scenario which we face many times is refractory SRF. Many times we treat and we see that there is some fluid left behind. Do we continue or not? So this has been specifically looked into this fluid trial, which found that SRF less than 200 microns can be tolerated well, and visual acuity is non-inferior in compared to other patients. And to extend it further, the Harbor and CAT trials have shown a little protective role for SRF, preventing macular atrophy, and probably there is a trophic role also for SRF. The next important fluid is intraretinal fluid, and contrary to the SRF, it is the most important negative biomarker associated with vision loss, macular atrophy, and fibrosis. Visual acuity is always poor at baseline in these patients, and lower improvement with intravitreal anti-VEGF is seen. And if the intraretinal fluid is seen to be persisting in spite of treatment, then the prognosis is going to be even worse. Sub-RPE fluid appears to be the least important, and it is only significant if it is present with other fluids like SRF and IRF. Usually they have a good visual acuity at baseline, and complete resolution of PED is not associated with an improvement in visual acuity. So we need not continue injecting in these eyes only if there is a PED. And also some studies, especially that small crescent of SRF you see on top of a tall PED, when it resolves, leaves a little bit of macular atrophy. And coming to the structural markers, we have the photoreceptor layer integrity as shown by the ellipsoid zone and the ELM band. And we know that if it is affected, usually the visual acuity is poor at baseline and continue to be poor after anti-VEGF therapy. But if it is, in some cases, it can get restored. In those cases, visual acuity seems to improve also. High reflective dots, these are small high reflectile dots, 40 microns in size, less than 40 micron in size, usually on the outer, very close to the outer layers. And they represent poor prognosis and is seen more in non-responding patients. Outer retinal tubulations, these are small round structures seen close to RP or the SHRM, and these are actually the consequence of photoreceptor degradation. And usually when the photoreceptor get damaged, the ELM starts crawling over it, forming what is known as a foaming ORT. And once it encloses the thing, it is known as a formed ORT. Formed ORT can be closed when it is 360-degree encircled by the ELM, and if there is a central lumen. So what is important is that visual acuity, central macular thickness, and retinal sensitivity. All these three parameters are worse in those eyes with ORT. But some studies have shown that geographic atrophy worsening is little slower in patients with ORT. Anti-VEGF treatment does not affect the appearance or disappearance of ORT. Subretinal hyperreflective material or SHRM is hyperreflective material seen under the retina, may be composed of fibrous tissue as well as other components of CNVM, and is associated with a poor visual prognosis, especially when it is in the central fovea. Other features of SHRM like layered appearance, hyperreflective spots, SHRM, separation from the outer retina, larger size, all these are associated with a negative correlation with visual acuity. And if the SHRM lesions are decreasing in reflectivity when you are injecting a patient, that means the visual acuity may improve in those patients. RP tears are something of concern for all of us when we inject in AMD cases. Most of them are from fibrovascular PED. The other risk factors are height of the PED more than 600 microns and a large basal diameter on fluorescent angiography. Also, small MNV size to PED size ratio less than 50%. Also, some RP irregularities along the RP border, such as RP thinning, RP indentation, and small interruptions on PED onicity are all risk factors. What do you do after you get an RP rip? The current evidence seems to point that you continue injecting anti-VEGF injections, especially if the CNVM is active. Visual acuity is not usually affected unless the RP tears runs through the center of the fovea. VMA is another poor prognostic indicator. These eyes tend to take a lot more injections than other eyes, and surgical removal of VMT for other reasons seems to benefit the course of disease and also reduce the number of injections. Sub-RP hyperreflective column. These are small, narrow bands of hyperreflectivity. Unlike here, you see the broad one is due to geographic atrophy, backscattering, but this is differentiated from the sub-RP hyperreflective columns. These are small, narrow bands, and they are also associated with poor prognosis. Pre-choroidal clefts, these are outward bowing of the choroid in between, just beneath the thickened choroid. And usually these eyes maintain good visual acuity and the risk of RP tear is low in these eyes. Choroidal caverns are non-reflective spherical or polyhedral cavities seen on ENFAS OCT more. And there is a posterior tail of hypertransmission. And histopathology has shown that these correlate with lipid globules in the choroid as well as in subretinal space. And the other choroidal parameters, especially subfoveal choroidal thickness, which has been studied in detail, is not significant because it is not related to visual acuity nor to response to intravitreal anti-VEGF therapy. So coming to the biomarkers in diabetic macular edema, again, fluid form the majority of the biomarker. You have to look for signs of chronicity and structural damage here, and prognostic markers as well as response markers. And also, in addition, we have systemic systemic inflammatory biomarkers which correlate with OCT biomarkers. Fluid in DME is slightly different from AMD because the source itself is from the inner blood retinal barrier, whereas in AMD it is from the outer BRB. And we see more often intraretinal fluid is almost always present and SRF is lesser. And we have large number of cysts in these eyes. From the RISE and RIGHT trial, we have seen, as well as RESTORE trial, we have seen that larger SRF, then better the response to intravitreal anti-VEGF injections. CST is the most studied biomarker for DME, but it is not prognostic or predictive of final visual outcome. Instead of that, now newer higher order OCT biomarkers are emerging like RFI, that's a retinal fluid index, which is actually a ratio of IRF, intraretinal fluid, to the total retinal volume. So that correlates better with visual acuity. Also, it gives an idea of the stretching index, which means that if the fluid IRF is very high compared to the total retinal volume, those retinas are prone to more stretching and damage of the bipolar axons, creating permanent degenerative structural damages in the retina. And the next most important studied or very important biomarker is the disorganization of inner retinal layers. It is the GCC complex, the ganglion cell IPL complex. The border between the INL and the GCC complex is lost in these eyes. You cannot clearly see the demarcation. Sometimes, in spite of here, you can see that still the demarcation is present in the inner retinal layers. So this is very important biomarker, and it correlates even in eyes without. In eyes with DME, it correlates with poor prognosis if it does not get restored. And if in eyes without DME, it suggests capillary non-perfusion at macula or macular ischemia. And now studies have shown that even eyes without diabetic retinopathy, drill may be seen, and it is an early sign of neuroretinal impairment. Hyperreflective dot echoes or HRF, these are small hyperreflective material less than 30 microns in size, don't cast the shadows unlike the hard exudates or microaneurysms. And these are usually seen initially in the inner retinal layers. You can see here in the initial stage before starting treatment, these hyperreflective foci are more in the inner retinal layers. And as we inject, they tend to migrate outwards towards the outer retinal layers. So studies have shown that the steroid response to steroid is slightly better in these eyes with HRF, but also there are studies which tell that the recurrence of macular edema is faster in patients undergoing steroid injection if HRF is present, as seen in this case you can see just within 3 months of injection with tricot, the patient has had recurrence of macular edema. And if you look at the last picture of the same patient, after all the number of injections he has had, you can see the migration of the HRF to the outer layers, and some of them tend to form backscattering and forming hard exudate. Also, you can see the degenerative change. This is a large cyst extending from entire length of the retina with outer layer changes happening here, which is a degenerative cyst. So all these are more commonly seen in patients with HRF. Another recent biomarker that has come up is foveal eversion. I will just show a demonstrative case. This is the same one patient do different eyes. Right eye showing foveal eversion, that is a foveal normal foveal dip is lost, and the other eye has almost same amount of macular edema, but the foveal dip is present. This patient started getting injections in May 2016 and keeps on getting injection 2017, 18, 19, 20, 21. Okay, this is the last picture. I'm not going to details of what all was injected. Only concern is the last what happened. The vision is 636 and anatomically there is some amount of fluid persisting in spite, in this eye, the right eye which had the foveal eversion, whereas eye which didn't have foveal eversion, the left eye did well with anatomical as well as functional improvement. So this shows the importance of foveal eversion, which is a poor prognostic marker. Then comes the cystoid space. You have to analyze the cystoid that is in DME carefully. The outer nuclear layer cysts or the cysts which are filling the entire breadth of the retina, as I earlier told, are usually associated with poor prognosis, usually larger than more than 200 microns. They are associated usually with outer layer defects, whereas inner nuclear layer cysts are not that bad. And also what is inside the cyst also has to be seen carefully. These are small bridging connections between inside the cyst. If you can see here, they may be faint, but it is there. So this is a good prognostic sign. If it is present, these patients tend to recover visual function after the anatomic structure is restored. Pearl necklace sign also shows a chronicity. These are high reflectile echoes inside the cyst, bordering the cyst, and is a sign of chronicity. And what is inside this is sometimes clear fluid, sometimes there is a intracystic hyperreflective material. Octas shows this to be suspended particles, scattered suspended particles in motion or spin, and these are also associated with poorer prognosis. And as we all know, the outer layer is also very important. Discontinuity in ellipsoid zone can portray poor prognosis in these cases. Just like hyperreflective foci inside the retina, you can have it in choroid also. This is more correlating with ischemia in diabetic retinopathy eyes and is associated more often with PDR eyes. And another interesting biomarker is the photoreceptor outer segment length or the PROS. That's a distance between the ellipsoid zone and the RPE. So this is a very good marker of visual acuity in patients with DME, mainly because this corresponds to the outer segments of the photoreceptors, which are actually opsin reservoirs. So this correlate better with visual acuity. So coming to the conclusion, in AMD as well as DME, these OCT biomarkers serve very important diagnostic and therapeutic role, and they are very predictive of what is going to happen. You can know the vision, prognosticate the vision, and in many cases it will tell you when to stop treatment, and also will give you a clue of safety and risk associated with injecting or in these patients. Thank you. I hope I didn't go too fast with the talk.
Thank you, Prakash. I know it is literally impossible to cover all the biomarkers in the stipulated time, but I think we heard it well and you were slow enough. Yeah, drill, I would definitely agree, one of the most important biomarker that we use in our day-to-day clinical practice. So it's actually measured as 1 millimeter involving the center of the fovea. As a clinician, it's easy to see that because the disc is around 1.5 millimeters. So if you see a lesion which is around 3/4 of the disc drill, and you know that is a poor prognostic biomarker. And also, an ELM breach is something which people postulate as a reason for shift of fluid from the subretinal fluid to the intraretinal spaces. Well, we are talking about a lot of biomarkers, but as findings which can be used in day-to-day clinical practice, probably some of them is still yet evolving. Regarding AMD, there are many more, but due to lack of time, we are not able to. I think Prakash just mentioned the most important clinically significant ones. And dry AMD, yes, more and more biomarkers are looked into now, like the RP, PLOM, and hyperreflective 4K intrusions. But still, we are yet to use it in routine clinical practice to actually prognosticate these. These biomarkers are good or bad prognostic biomarkers. Thank you very much, Prakash.
Thank you, Shane.
Okay, there is a slight change in our schedule as Prashant Bangule sir has not yet reached. We are going to a next talk by Thomas Cherian sir on intravitreal pharmacotherapy. There is no need for introduction of Thomas Cherian sir. He is a senior consultant, head of Retina department at Little Flower Hospital, Angamali. Welcome, Thomas sir, for the presentation.
Thomas, have you started your presentation? You're not audible.
Okay, let me try to go back.
Yeah, we can see your presentation, but yeah, now you're audible. Now you're audible. Yeah. We could see your presentation. Yeah.
Okay. What we have in the market today are Avastin, Accentrix, the biosimilars of ranibizumab, Eylea, Paginax, and also Dex. That is what we have in the Indian market today. Anti-VEGF therapies have redefined the care of patients with retinal diseases over the last 2 decades. At least some of you might remember the grand launch of Macugen we had in Goa in 2004. That was the first anti-VEGF pegaptinib sodium to hit the market. The licensed anti-VEGF, that was Macugen, was the first one, but that is now part of history. Then we had Lucentis coming up in 2006, which was later rechristened as Accentrix. Then Eylea came in 2011, followed by Paginax. What is the role of anti-VEGF? Or vascular endothelial growth factor, what is the role of VEGF? VEGF is a 45 kilodalton homodimer molecule, glycoprotein, which potently increases the retinal capillary permeability and subsequent retinal edema, in part by inducing a breakdown of blood retinal barrier. How has the evolution of DME treatment come up in the past few decades? Prior to 1980, we had no treatment for diabetic macular edema. We could virtually do nothing. Then in the 80s, we started off with photocoagulation, first grid photocoagulation, followed by focal laser photocoagulation, which could halt the progression of the disease to some extent. In the 90s, we started injecting steroids. And from 2012 onwards, we started anti-VEGF therapy for diabetic macular edema, which were aimed to improve and optimize the treatment. And now our aim is to optimize treatment, that is 2019 and beyond. Avastin we used for many years. From the start of this millennium, it was a full-length humanized monoclonal antibody, which was directed against all the biologically active isoforms of VEGF. It played its role in the initial years of anti-VEGF therapy, but with the availability of a lot of other molecules within the affordable limits, the use of Avastin is very much limited now. From a personal note, I have stopped using Avastin for the last 5 years, and the institution where I work, we don't have Avastin at all in ophthalmic practice now. The innovator brand of ranibizumab, Lucentis, is the international brand, and it has been rechristened in India as Axentrix. It significantly contributed to the treatment of AMD or PCV and retinal vascular diseases, including the retinal vein occlusions and diabetic retinopathy. We have a lot of strategies in treating these diseases with Axentrix, that is monthly doses, loading dose, treat and extend, PRN. All these strategies we use. Use of ranibizumab or Axentrix in wet AMD are on the basis of the anchor trials, the Marina trial, the PIER and the Excite. In RVO, we had the Bravo and Cruise, followed by the Horizon trial for extended use. In DME, we had the Rise and Ride, followed by the DRCR-NET and the Protocol I. Early treatment gains. So this is about the RESTORE study, where we compare laser with ranibizumab and ranibizumab plus laser. Definitely ranibizumab has an edge over laser in management of DME. In Protocol I, it is again ranibizumab plus prompt laser compared with ranibizumab with deferred laser. There is a significant difference. There is a significant advantage of ranibizumab with deferred laser. So ranibizumab has its role in management of DME. As regards the biosimilar, we have at least 4 molecules in the Indian market. We have Razumab, Rani-Ice, Ranizurel, and Osiva. The Intas ranibizumab or the Rasumab was the first one to hit the Indian market. They came out after phase 3 and phase 4 trials, approved by the DCGI and licensed to market the drug in India, first for AMD and PCV, and later on for DME. So they had the phase 3 and phase 4 trials completed, following which the drug was launched. And in the biosimilar, later on, the Indian studies were Reenact 1 and 2, the CSA study, the Crown study, the Disha study, and the BIRA study. And the awareness of using biosimilars was proven by the VRSI survey, which was done a couple of years back. Aflibercept, we still have only the innovator molecule, Eylea, which was launched after the View 1 and the View 2 studies. It's effective against all forms of VEGF and the placental growth factor. And it's the only widely approved agent that blocks all VEGRF1 ligands and the 2 ligands. In wet AMD and PCV, Eylea has a better drying effect. And in DME, it's more effective in patients with a visual loss of 20 or 50 or more. In Protocol T, there's a clinically meaningful visual gains with aflibercept, which were maintained through year 2, regardless of the patient's baseline vision. These 2 graphs show, they compare Eylea with Lucentis and bevacizumab, and Eylea maintains a good vision compared to Lucentis or Avastin. Protocol T shows that Eylea was associated with rapid and robust anatomic changes that were superior to those observed with both comparators at year 1 and maintained through year 2. Brolucizumab is a newer drug which has come into the market. It has more VEGF binding ability per volume. It has penetrated the retina rapidly in preclinical studies. It has a high retinal but low systemic exposure and a rapid systemic elimination. Brolucizumab, the primary trials were the HAWK and Harrier in neovascular AMD. It proved its non-inferiority to aflibercept, needs less frequent injections. As regards DME, Kestrel and Kite were the studies which showed robust improvement in BCVA from baseline, but with reduced injection burden, and early intense treatment with brolucizumab led to better anatomical outcomes as regards both the fluid and the central subfield thickness with reduced injection burden. We also have the dexamethasone implants, which were initially approved for retinal vein occlusions and later on for DME. In diabetic macular edema, inflammation is a major factor in the development of macular edema. It is important to acknowledge its role in fluid accumulation as the inflammation occurs early and before macular edema. Therefore, early treatment can control inflammation and prevent the development of edema. So we have a few points to consider in patient management in diabetic macular edema. That is, one is the baseline visual acuity. Second is the duration of the DME, that is chronicity alters the treatment responsiveness. The ocular environment and local pathological changes. For example, if you have an epiretinal membrane, it affects the management. Systemic factors. Initially, we had problems with treating patients with cardiovascular and neurological stroke diseases. But of late, the nephrologists have also developed their reservations for treating the patients with anti-VEGF. In all these, intravitreal steroid implants are the alternative. There's a variable treatment responsiveness to anti-VEGF, steroid, and laser in presence of a multitude of pathogenic pathways. As regards the visual improvement, it also depends on the chronicity of a DME. There is destruction and disorganization of retinal tissue, and VEGF increase is no longer the sole pathogenic mechanism. Treatment with Ozurdex is associated with a significant mean improvement in visual acuity of 4 lines in treatment of DME refractory to anti-VEGF therapy. Clinicians should be aware of patients who are responding inferiorly to anti-VEGF and consider corticosteroid therapy to improve the visual acuity outcomes. To sum up, Ozurdex efficacy, it targets multiple inflammatory mediators, not only VEGF. It has a good efficacy in both short and long duration DME patients. It has a long duration of action. There's a low injection regime, less burden for the doctors, patients, and the payers. Patients may respond after unresponsiveness to anti-VEGF therapies, and patients previously treated with laser or anti-VEGF can be treated with Ozurdex. It has minimal or no systemic side effects, a transient increase of intraocular pressure, and cataract are the ocular side effects, which can also be treated to the patient's satisfaction. Now let's go into what is there in the pipeline. We have faricimab, which is already there in the global market. Aflibercept biosimilars are under trial, and we are looking forward to gene therapy. As regards faricimab, it provides a sustained and effective treatment. There is an evidence for the role of angiopoietin-2 and VEGF-A dual inhibition in neovascular AMD and DME. And faricimab is a single molecule that stabilizes blood vessels by targeting angiopoietin-2 and VEGF-A, the 2 key drivers of retinal and choroidal vascular diseases. Anti-VEGF therapies have redefined the care of patients with retinal diseases. This is how it went from pegaptinib to ranibizumab to aflibercept to brolucizumab and now to faricimab. And the neutralization of both angiopoietin-2 and VEGF-A, the 2 distinct pathways, may lead to more sustained vascular stabilization over anti-VEGF-A alone. The trials which support faricimab are Retina and Lucerne. More patients treated with faricimab achieved first absence of intraretinal fluid and subretinal fluid faster and with fewer injections compared to aflibercept. And over 2 years, faricimab has demonstrated a durable efficacy and anatomical improvement with fewer injections in neovascular AMD. More faricimab patients had resolution of macular leakage versus aflibercept in the matched dosing period with Yosemite and Rhine trials. And the clinical differentiation of faricimab has a dual pathway inhibition. It has a faster drying, disease control, extended durability. Now, the aflibercept biosimilars phase 3 trials are underway. And once the patent of Eylea expires in 2025, we expect the biosimilars to be in the market. I'm also part of one of those trials where the molecule is currently named as CTP42, which is being compared with Eylea. So let's hope that aflibercept treatment also becomes affordable in the near future. What is much more promising as regards treatment of neovascular AMD is something which is like a dream for all the retina practitioners, that is gene therapy in management of neovascular AMD. What we understand is that the phase 1 and 2 trials are already done, and it is promising, and we expect a single intravitreal injection to be curative for neovascular AMD in the years to come. Thank you very much.
Thank you, Thomas. So I think you gave the talk for the next session, isn't it?
Yeah, I gave the talk for the next session. We had to advance it for some.
Yeah, I understand.
But whatever discussion we can have, we'll have it now, because the next session starts only at 6.
Oh, okay. Do you still depend on OCT parameters to decide whether to give steroid or anti-VEGF? Or what is your points to decide whether you want to give steroid or anti-VEGF?
In which condition? In RVO or DME?
To vascular conditions, basically.
Yeah, primary treatment is still anti-VEGF for me. But wherever it is a chronic condition where we have OCT parameters which might point towards a poor effect of anti-VEGF, that is one indication where I go for steroids. Then patients with stroke, patients with cardiovascular diseases, and now of late, patients with renal compromise, which are quite a few in number. So all that, I prefer steroids. The pregnant women, many a time for medical legal reasons, we prefer steroids over anti-VEGF. So otherwise, primary treatment is with anti-VEGF. And later on, if it goes into chronicity or poor response to anti-VEGF, which switch to steroids.
Recently, hue and cry has suddenly come up regarding use of anti-VEGF and renal profile. I think we have been using it in renal patients all this while, but off lately there is a lot of discussion on this. Interestingly, I had this nephrology department head's relative who underwent anti-VEGF therapy, and we took renal profiles before and after anti-VEGF therapy for almost a month to show that there wasn't much of change. So maybe it was for a single injections. But what is your thought on?
Yeah, that's exactly what I've been telling. The nephrologists have of late given the reservations about it. But practically from our side, we have seen that anti-VEGF is not worsening the renal profiles. But I think there have been quite a few reports in the nephrology journals about the use of anti-VEGF and affecting the renal profile of the patients. That's why the nephrologists are a bit skeptical about giving their clearance for anti-VEGF. But if they say no, we have no other option but to go for steroids. One or two cases where I had a PDR with DME, patient was going for renal transplant. There, what I did was I injected a steroid. Then in 1 week, I started the PRP, completed it in 1 month. And then send the patient for the renal transplant, because for the next 4 or 5 months, you're not going to get back the patient.
Dr. Sindhu, would you like to comment on it?
Okay, sir. See the hyperreflective dots as per the previous discussion, it is more of inflammatory. So if there are more hyperreflective dots, do you consider steroid injections?
Yes, hyperreflective
Correct.
dots, certainly an indicator that anti-VEGF might have a poor response and steroids might work better. But even in such,
Saravanan, your comments?
I just wanted to ask on like currently, how do you use Paginax in your practice, Thomas?
Paginax again, I have not used as a primary drug in any of my patients, but those patients who had Axentrix or who had Avastin or who had Eylea and who are going into chronicity, the intervals between the injections are coming down over the last couple of years. I've used Paginax in quite a few patients. They have reasonably good response. Maybe I would say the drying effect is a little bit better than Eylea. And so far, I've not had any inflammation or any reaction with Paginax.
I use it regularly in AMD cases. And I'm of the same opinion as Thomas that, I've I had one instance of inflammation all this while. Just one case which responded very well to steroid therapy with good visual acuity. Do you people still use it in DME? Has anybody started using it in DME?
I've used in 2 patients and 2 cases of vein occlusion as well, but these were people who were not responding to the routine therapies, but not as a first line definitely. And as regards to renal failure status, remember like FFA, we used to be doing it in renal patients, fluorescent angiogram, even fluorescent angiogram. But if you ask a nephrologist, they'll say that fluorescent angiogram is not contraindicated in patients with renal failure because it's unlike the dye which they use for MRI or for CT scan, that is more harmful, which should not be renal failure. But for the fluorescent angiogram itself, there's no issue even if there is renal failure. That's what our nephrologist says.
And
Shane, I have used for Shane, I have used for one case. Yeah, one case I have used DME Paginax that was not responding to Eylea at all. And the response was very good, but only problem was there was no inflammation, but the vitreous became slightly hazy in that patient. And he is also complaining of that. He is complaining there is a little cloudiness. The macular edema resolved beautifully, and it almost now 4 or 5 months it has not recurred. So I was following every week. It was actually a doctor also. So every week I was calling the patient to look for inflammation. So it was frightening whether it was going for an inflammation. So after that, not given. Vitreous slightly became hazy, but no vitreous cells, no antechamber cells, nothing.
Dr. Brown from Texas, he was telling that to pick up these subtle inflammations, you can do a RNFL analysis, sequential RNFL analysis. Look at the RNFL between the pre-injection and post-injection era. If there is increase in the thickness of the RNFL, that will be the earliest sign of inflammation, because all patients may not come up with the severe inflammation which the other people have described. Subtle inflammation, you can see it in RNFL analysis. So in case you're having a thickening, better to switch out to some other drug or else give gap between the injections so that it comes down in between.
Post-vitrectomized eyes are situations where I give Paginax nowadays. And I feel definitely that, it was in a vitrectomized eye, we all know that the effect of anti-VEGF wanes off fast because of the loss of reservoir effect. And here I've actually got Paginax in, and I think the duration has definitely prolonged. So that's one situation where I definitely choose Paginax nowadays. Yeah.
I've never thought about this. Normally, I will go only for Dex because all other drugs do not work well. But this is good news actually.
Thomas,
will it be difficult?
Sorry?
No, will it be difficult to assess inflammation with vitrectomized eye?
Yes, that is a possibility. That is a possibility. But over the time, I'm very convinced that the rate of inflammation is Paginax has dropped down so dramatically. So that is what is giving me confidence to give it in more number of cases, especially with vitrectomized eyes. Yes, you had a point. It will be difficult to assess inflammation. But from the report in US, we knew that it was mostly vasculitis and vein occlusions, which was common with Paganax-related inflammation. So that is something which you can still detect when we do fundus evaluation, even in vitrectomized eyes. So those were the thoughts which are coming in my mind.
Hi, sir. So in a case of DME, if you were to inject Paganax, how would be the frequency? Would you be injecting it every month, or probably delaying the frequency?
That's the PRN regimen. I'll wait for the edema to reappear and then inject again. Obviously, I will not do a treat and extend or even a monthly schedule. I mean, as a matter of fact, in DME, Paganax study, they've used once in 1.5 months. That's another interesting thing which just came up. They did not use it monthly for the initial loading dose. They used it every 1.5 months. So that is also a clear evidence that it is a drug with a better drying capacity, as rightly Dr. Thomas mentioned.
So just to ask, like in AMD cases, do you give Paganax loading dose, or?
Yes, I do give, especially, so I don't give in treatment. I mean, I am still reluctant to give in treatment naive patients, but patients who are not responding, or I see that the fluid is increasing, or a new PED with the SRF has started, then I tend to use it monthly, 3 months, and then probably treat and extend with Paganax itself. That's the protocol which I follow. How about you, Divya?
With Paganax, actually, I don't give a monthly, like a loading dose these days.
Yeah.
Because I do see that I follow up the patient with the sequential OCTs. But as like maybe 2 months, 3 months, if I feel that it is slightly coming up, then only I give actually with Paganax. And I nowadays give it as a primary therapy also.
But initially, I started 3 years back. I started giving Paganax 3 years back. Initially, when I was giving, I was very reluctant, and I used to give PRN or maybe in very, very unresponsive cases. But over time, as I told Prakash, I don't know whether it's overconfidence, but I definitely feel that the rate of inflammation has come down dramatically. I don't know what has happened. Have they changed the structure of the molecule? Have they done any other cell line cultures? I really don't know, but I definitely feel, and I'm sure many of you injecting also would feel that the rate of inflammation, what is described in Western literature, we don't get. So yes. I'm probably overzealous, I would say. The reason why I hit it hard is because initially when there is a recurrence, our primary aim is to reduce it to the maximum. And I know by sustainably giving it for every month, 3 months, which is according to the study initially given, that really brings down the disease. And then probably
we move on to the next session.
Yes.
Yeah,
sir.
Session is on medical retina, and I'll be introducing the speakers. First speaker is Dr. Gopal. He is not available with us today physically. He's flying, so we have a recorded video. Dr. Gopal is familiar to all of us, especially after his vibrant tenure as COC during the COC secretary during the pandemic. He is head of department and vitreoretinal services at Amrita Institute of Medical Sciences, Kochi, and he's also the present secretary of Kerala Society of Ophthalmic Surgeons. Dr. Thomas?
I think I was told that there is a problem with
there is Gopal's video had already reached, but then Prashant Bavangule, who was supposed to speak in the last session, has just landed. So shall we call Prashant and have his talk first before we go into the other two? Prashant Bavangule is talking on OCT angiography.
Who's moderating, Dr. Thomas? Who's moderating?
you can continue to moderate because it was part of the first session, but since Prashant's flight had not landed.
I mean, who's moderating this session? I mean, basically.
This session, Sheena Lismani is moderating and you are the chair.
I'm here, sir.
Fine. So Sheena, the thing is, I may just have to move out around 6:45.
All right, sir.
Okay, yeah, okay, yeah. Hi,
Please.
Prashant, please go ahead and give your talk. I think you're inside the car, right?
Yes, sir. Yes, sir. Good evening. Sorry, let me share my presentation first.
Yeah.
Is my presentation visible now?
Yeah.
Hello?
Yeah.
Okay. Thank you, KSOS for this wonderful opportunity. I'm extremely sorry. We had a managing committee meeting which got announced and my flight got delayed. And so all the fuss, I'm really extremely sorry. Now coming to back to my topic, I'm supposed to introduce to the audience the OCT angiography. Well, everyone knows it's a non-invasive measurement of retinal blood flow based on diffractive practical movement direction using a laser light refractors. This is what happens actually. 4 sequential OCT scans are acquired from the same space within a very short space of time. Then they are processed and they construct an image which looks something like this, which is a reconstruction of actual vasculature and the flow of the blood inside it. Now let us look at the principle for the sake of postgraduates. 2 beams, one is a reference beam and one is the actual beam. One goes through the solid tissue, one goes through the vascular tissue. And simultaneously, such sequential scans are taken from the same tissue. And what you get is that A2 is the scan which is moving through the solid tissue where there is no movement, and therefore it ends up having a flat line like this when the data is processed. While when it moves through the area into the blood vessel where the RBCs are moving, you get a spike like this, and this is because of the blood flow which is happening. And this happens because of the decorrelation. Now, decorrelation, let us understand, can be of 2 types. When decorrelation, when the tissues are moving, when the solid static tissue is there is no decorrelation, and that's why we saw that we get a flat line. But decorrelation in the blood vessels can happen because of amplitude or phase decorrelation. So phase decorrelation is because of the signals coming at later period. And this is phase decorrelation, which is the principle used in Zeiss octas. While in amplitude scans, you have amplitude decorrelation, which is available with Optive. The reflectance, the amplitude is correlated. And these are some of the terminologies which we need to understand. So whenever there is an amplitude decorrelation, it can be coded from 0 to 100, and higher the decorrelation value, as you see, you will see the higher blood flow velocity. And if it is low, it means there is no blood supply to that area. These are the various products which are available today in market based on which type of octa approaches is what I have shown over here. So now let's come, what are the advantage of this system? Here, as we do not use intravenous dye injection, naturally the side effects related like nausea, vomitings are not there. Importantly, you can do a repeated scan immediately a second later. While in a fluorescent angiography, if you ever miss out certain phases and you need to repeat, it should be done after about 48 hours minimum. Third most important thing, the NFAS view which we get in a fundus fluorescent angiography, you can get a one level view of it. You cannot segment it, which can be possible at a various levels of retina and choroid, which is possible only with octa. And the area of non-perfusion and neovascularization can be actually very well measured, less time consuming. The only limitation is that the sign of activity of a vessel structure which we are assessing in the form of leakage and staining cannot be assessed in octa. But yes, if you have a combination of OCT where you see fluid, which again is an indicator of activity of that particular membrane, well, it can be compensated. Other important thing is in a fundus fluorescent angiography, the vascular structure in initial phase very fast phase it out or buzzes out because of the leakage. While in an octa, as you see here, neovascularization, the microvasculature remains as beautifully seen throughout the phases, and you can repeat a number of times. Another example where you see the beautiful vasculature on an angiogram, which becomes blurred out, while in an octa, you can actually see the skeleton of the skeleton or the structure of the microvasculature. Now let us understand the analysis in octa. This is NFAS view, that is a 2 view of a segmented tissue. Well, segmentation is what is most important in these cases where you get a volumetric flow information at various levels of the retina and choroidal tissue. And to segment it, you can either use slabs or slices. Slab is a thicker tissue section, while slice is a thinner section. As this is a slab which is taken, and then it can be further the keratin-like things, and we can get a further smaller slices. Now, you have to understand there can be superficial and deep slabs. As you get a 3D structure of the retina, it's a voluminous structure. And you, at various superficial and deeper slabs, you have to look for various structures, various anomalies which you are looking for. In retinal vascular disorders, you can pick up the ischemia and non-perfusion, whether it is at the inner retinal layer, outer retinal layer, or which vascular plexuses. In the deep disc also, when you're assessing, you can see deep retinal capillary plexus as well as radial peripapillary plexus. This is what the normal things. You see superficial, deep, outer retina, choriocapillary layers assessed by segmentation. While this is RPC when you are studying this, retinal peripapillary capillaries, and this is at the choroidal levels. You can use this while you are trying to evaluate a structure. Now, let us understand two concepts. Whenever there is no flow signal, non-vascular flow signal, it happens because of blocking of the background blood tissue motion, as you've seen, because of exudates or retinal pigment epithelium or retinal hemorrhages, while avascular region happens because of devoid flow signals, that is a capillary non-perfusion areas. Now, these are flow projection artifacts. I will just run through it. Few terminologies which we need to remember is a flow index, average decorrelation value. Vessel density index is one of the most important thing. It is a percentage of area occupied by vessels. And you need to understand this is the normal vessel density of a index of a macula in a normal human being. And at the disc, it is something like this. These values are not yet substantiated. Few of the studies have shown what should be the vessel density, and we should remember this when we are trying to understand how much is the vasculature supply of that area. While we are trying to analyze, we need to understand, go back to the basics of anatomy. There are three vascular complexes. One is superficial, one is intermediate capillary plexuses, deep capillary plexuses. Superficial vascular plexus happens at a ganglion cell layer and nerve fiber layer. Intermediate capillary plexus happens here. You can see at the inner plexiform layer, and deep capillary plexus happens at somewhere between inner nuclear layer and outer. The outer part of the retina is avascular. So any vascular activity you see here is you have to look at it with a more suspicion. Now, these are the 4 zones which we see in a normal human being, and this is what the characterization you should remember. Now, what are the abnormalities which you should look for in different zones when you are analyzing this particular thing is? So I will come directly to this. For telangiectasia or microaneurysm, it is the superficial layer. You see the telangiectatic vessels over here. When you are looking for a vascular structure like this, high vascular thing in a deeper plexus, then it is naturally a CNVM. Now, in outer retinal thing, as I said, is a vascular structure. If you see a vascular plexus like this, then it is a CNVM. And sub-RP, again, usually is a vascular thing. And you see any complex, this is how you look for various structures. So you should be clinically trying to correlate and look for that particular slab on your own. Now, look at this particular patient, young hypertensive, sudden loss of vision. And we were not able to, clinically, he was looking absolutely normal on a fundus photograph. Superficial vascular plexus is absolutely normal, but when you look at the deeper plexuses, you can see a void over here. Well, this was hypoperfused areas in the deep, and this was nothing but a deep vascular infarct happening because of a thing which we could not explain clinically. Now, how do we analyze the abnormalities which are seen on an octa? There are 3 things which we need to look for. Abnormal placements of the flow, either in the form of neovascularization or choroidal neovascularization. Abnormal geometry of the vessels, as you see, in the form of dilated and tortuosity. And the third is absence of flow, that is capillary non-perfusion. These are the 3 abnormalities which you should look on an octa when you are analyzing at various depths. So abnormal placements of the flow in superficial slab. This is telangiectasia versus a microaneurysm, which is an outpouching for the capillaries. This is intraretinal microvascular abnormalities, neovascularization on disc and elsewhere. And this is a hemangioma at a superficial level. Now, at a deeper level, what neovascular abnormal presence of flow you can see is because of the CNVMs, as you can see in this particular slab. Always compare it with OCT. Now, look at this clinical example. This patient presented to us with a impending central retinal vein occlusion with the macular edema. And this is how, after 2 months, you can see at the slab, the reorganization and the development of the vascular pattern, which was missing there. So this is how we can follow up a case of a central retinal vein occlusion. Now, after analyzing the macula, you also need to analyze the optic nerve head at 4 zones. One is the optic nerve head level. One is at the vitreous opacities above optic nerve head level. Then radial peripapillary capillaries and at the choroidal levels. These 2 levels are important, RPC and choroid, when you are evaluating a patient of a glaucoma. Now, let us see some of the abnormalities associated there. This is NVD, which you should look at a vitreous slab level, while a collateral is seen as a small loopy vessels at RPC slab level. So exactly you should be knowing what pathology you are looking for and what level, and you should manually segment to have a look at all these activities. For when the patient of glaucoma is being evaluated, 2 slabs, that is RPC is the level where you should look for loss of RNFL and choroidal vessel loss in parapapillary region. And these are the indices which are being described. Typically, this is subjective indices at superficial level, that is RPC. You can see the loss of the radial peripapillary capillaries. And in deeper lamina cribrosa level, you can see the choroidal infarct, rather choroidal loss of parapapillary choroidal MVD, what you call. And objectively, they can be substantiated. How much is the vessel loss by having peripapillary vessel density, parapapillary choroidal vascular density, and the flux index and perfusion densities, which are the matter of interest and the matter of research. How much should be the flux index, perfusion density of various regions, and that helps you in monitoring. Now, this is a case which is borrowed from this particular journal where it shows inferior notching. You can see the RNF loss over here. And
Prashant,
yeah,
you have crossed your time quite a bit, Baba, please, because there are 2 more talks.
Okay.
Please.
Okay. So this is reduced vessel density. This is again the infarct at a deeper level. And this is pre-op and post-op photograph of the same patient where you can see the recovery of the vessel density in this particular region. So I will just run through it. And now I will just run through this few of this glaucoma cases. I will come directly to some of the retinal advantages of this in diabetic retinopathy. Well, we have to analyze the foveal avascular zone, which is most important. It has a normal variation, which you should be aware of it when you're trying to compare. You should definitely assess and there is an inter-eye asymmetry of FAZ, which you should be aware. But importantly, in a diabetic retinopathy, increased FAZ in a longitudinal way study always shows that there is increased risk of diabetic retinopathy. You can see vessel density, PD and FAZ circularity decreases, FAZ increases with diabetic retinopathy. These are some of the cases. Unexplained visual loss in an NPDR. We did a thing and we can see a void over here. It to help us in understanding the depth of the ischemia. Microaneurysms, something like this, which are patterns you can say understand. And these are the types of irregular fusiform, which increases the chances of leaking activity. Then I will come to telangiectasia. This can be picked up. This is again a microaneurysm on an octa. Another 65 years where you can actually on an octa very well document the amount of microaneurysm. The only limitation is the microaneurysms with a very high flow or a low flow are not picked up compared to angio. New vessels can have 4 types, which can be seen on an octas like this. These are very important things like pre-op, new vascularization. We did a lasers and we could see that this particular patient had a recovery or the regression of the vessels. Another case, the patient had a mild hemorrhage. We just did an angiogram. We could pick up a new vascular complex in the other eye and also ischemia in the periphery in the same eye. Status, retinal photocoagulation, you can pick up the new vascular without needing angiography. You can also monitor the response of a PDR and DME. Here, see the angios over octas. You can see the regression of the as well as the macular edema. Another case where you can pick up a new vascularization in otherwise clinically silent eye, where it was almost similar. Now coming to role in AMD, well, you can pick up the occult CNVM as you can see from this particular thing. You can pick up a false negative occult. Many of the things which are missed on FFA are also picked up similarly. This is a case of a shram with SRF where 3 weeks later and CNVM developed. And you can pick up, you can monitor the response as well. You can
I think his connection has gone, so we can move on to the next talk, Dr. Thomas.
Yes, I have already done. Dr. Abhishek will talk now.
Yeah.
Sheena, please introduce.
Yeah.
Okay, it's a pleasure to introduce our next speaker, Dr. Abhishek Kothari. He is presently Senior Consultant at Pink City Eye Center, Jaipur.
Also can pick it.
Pardon me?
Prashant, we have moved on to the next talk.
Okay. Dr. Abhishek is not only a skilled VR surgeon, but he's also equally very technically sound, and he teaches both ophthalmology residents and engineering postgraduates. He'll be speaking to us on the top 5 mistakes in the management of AMD and PCV. Dr. Abhishek.
Thank you so much, Dr. Sheena, for your kind introduction. And I thank KSOS for giving me this opportunity to present this talk. Now, AMD is something that I think all of us present on treat on a very common, on a day-to-day basis. And sometimes the results, the patient expectations don't go as well as we wanted it to. So what are the top 5 mistakes when we are treating AMD and PCV? I'll be just running through here. Now, I have no financial interest in any of the products mentioned in this talk. The mistake number 1 is that a lot of us do not get the patient's angiograms, the ICG or other ancillary investigations. We rely on OCT alone. This is more common for those people who visit multiple centers, anti-segment practices, and they have OCT and the treatment starts and continues with OCT. So to present the common mistakes, I'll just show some representative cases. So now this is a 65-year-old female treated for CSR. You see in the supratemporal area, there are laser scars, and there is a little bit of exudation also. Now this was the OCT when the patient presented to us, and the surgeon had advised her an FFA, and an FFA was done. So this was the FFA, and the treating surgeon actually said that this is still just chronic CSR and he can't find the leak. However, when the patient came to us, we did an ICG, and this was what the ICG showed. You can see a beautiful, how beautifully the branching vascular network and the polyps are seen. And we started treatment with anti-VEGF and the patient did quite well. Now, just to make this point, all PEDs on structural OCT are not serious PEDs like this particular case shows. They could be RAP, they could be CNVM, they could be PCV also. And this cannot be elucidated unless you've done an angiogram or a combination of FFA and ICG. So the first mistake is just relying on OCT alone. Now you may say that fine, I have OCT and I have OCTA. So now OCTA is enough. Again, case in point, these are 2 patients, patient 1 and patient 2. Patient 1 has a kind of a pruned vessel appearance and the patient 2 has almost like a medusa head appearance. Which patient do you think is the one that has activity? So you have to combine this data with your structural OCT data, and you see the patient in which the SRF is there is actually patient 1 and patient 2 is almost dry. So OCTA alone again is not enough. Variable flow patterns, both extremely high and low flow lesions are not visualized on OCTA. Segmentation projection artifacts happen because of large PD, because of hemorrhage, fibrosis, and extensive edema. So you need angiography also. OCTA alone sometimes fails you. So this is again an example where the OCTA shows CNV. Now, had the patient been treated alone on the basis of this investigation alone, we would have missed the polyps. So this is the ICG of the same patient showing the polyps and the branching vascular network. So it's a dictum that Octa shows the BVN better and ICG shows the polyps better. So to diagnose PCV, I think ICG is a must. Coming again to this case of extrafoveal subretinal heme. Now, what would you do? You'd probably just inject an anti-VEGF and keep injecting the anti-VEGF. This is what the structural B-scan shows. And this is what the Octa shows. So is B-scan and Octa enough? No. The ICG shows there's a bunch of polyps. Now, this particular patient was treated with anti-VEGF along with laser to the polyps because they were quite far away from the fovea. And the patient did extremely well with the regression of the polyps, and very few injections were required. Only about 2 injections were required, and the patient did well. So this is why I said that OCT alone or Octa alone are not sufficient in the management of AMD. Now, this is the pre and post treatment Octas of the same patient. Now, coming to mistake number 3, that is under-treatment. Under-treatment is a bugbear, and more so in India, where we switched to PRN very early on. But there are multiple trials and multiple long-term studies that have shown that the visual acuity, both at 1 year and 2 years, is always better when you do a treat and extend regimen versus the PRN. Most of us give 2 or 3 injections and then switch over to PRN, whereas treatment with the treat and extend regimen has been shown to be better for the patient, both in terms of vision and in terms of longevity of the result. Also, case in point is that in 2 years, most of these studies showed that between 2 to 3 excess injections were given in the treat and extend regimen, not too many like the fixed regimens. So I think switching to a TNE strategy is much better than doing a PRN work. This is again a very interesting table I got from an article in Graphics. Long-term visual results, if you see the PRN and the TNE, in the first 1 year, both of the regimens, PRN and TNE, did almost the same, with about 42% in TNE and about 36% in the PRN group of patients, that did better, had an improvement of more than 2 lines in visual acuity. But look at the 4 to 5 year results in the bottom. Here you see that only about 12.5% of patients that were on PRN retained that improvement in vision, whereas almost 42% of patients, 43% of patients with the treat and extend regimen still showed a significant improvement. The third problem all of us face, and sometimes, sometimes we have to do it because of socioeconomic reasons, is that we promise the moon. Now, multiple studies have shown, and a very nice review by Usha Chakravarti's group had said that, in 15 years of anti-VEGF, we still are experiencing disappointment. So there are multiple studies now. There was a very nice SDOCT study on NMD where they found out that in 2 years, 1/3 of patients that were in the Harbor study showed signs of macular atrophy. Also, this is the data from the EVAN trial that after the 2 years of the EVAN trial, when the patients are followed up till 6 years, the older patients, that's the bottom line, and the younger patients as the top line, tended to lose vision over the next 6 years. So over time, a lot of patients do lose vision in spite of good treatment. Again, this is from the CAT trial. They studied the development and the course of fibrotic scars in patients with CNVM in the CAT trial. And by the year 5, more than 50% of patients had developed a fibrotic scar along with pigmentation. So again, the next mistake now, a very important point is that, you have to look at not only the eye, but the patient. Several patients of ours are on Ecosprin, on Clopilot, on Ticagrelor, and on Warfarin. In the older age group, a lot of patients have multiple diseases. We usually don't ask aggressively and don't, try to find out what the dosage is or how it can be managed. There are multiple studies that have shown that aspirin and clopidogrel can be continued without any detrimental effect in AMD and NMD. However, with warfarin and with the recent new powerful antiplatelet drugs, you can expect a sudden subretinal hemorrhage or a sudden increase in the subretinal hemorrhage, even in patients that are on treatment. So we have to warn these patients accordingly. Also, the biggest factor that is, I think, completely ignored in most of our counseling is smoking. There are multiple papers that have shown that both dry and wet AMD, the impact of smoking is deleterious. The treatment results, the proportion of geographic atrophy, scars is more in patients that either smoke or probably even chew tobacco. So this is something that we need to keep warning our patients that if they are tobacco users, they have to give it up or the results are going to be suboptimal. So to conclude, number one, we have to, whenever we start treatment of AMD, we have to characterize the lesion completely, whether it is MNV 1, 2, or 3, and how we are going to, what is the location and how we are going to manage this. We need not ease treatment early on, and we have to continue treatment for a sufficient duration. The recent paper from Taiwan said that if you follow the treat and extend regimen, if the patient undergoes 2 injections at a 4-month interval without, again, reactivation of the disease, that is the time to stop, not before that. And do be realistic in your in what you promise to the patient. That makes their compliance also better, and you don't have to face an embarrassment. And look at the patient as a whole, not just the OCT or just the angiography. Thank you so much.
Thank you, Abhishek, for that brief and very nicely illustrated points that we all need to consider. Dr. Giridhar, do you have any points?
Yeah, I mean, I think I enjoyed your talk, Abhishek. I just want to add 2 points. One is that 2 areas which we forget. One is patient education. That's very, very important, because what I've seen in my practice is many patients, because of very poor education, they don't understand, they don't know about the disease. So they have to be very well educated about the long-term treatment, etc., the need for follow-up, what happens if you don't treat. So patient education is critical in the management of wet AMD. Number 2 is that follow-up. See, once we earlier in the beginning, 13 years earlier when we started anti-VEGF, once the macula became dry, I used to call the patient after 3 months. But now I call the patient the next month, because early recurrence is something that we need to treat. So 2 things, follow-up, emphasis. Number 2 is patient education, apart from all that you had said.
Right, I quite agree, sir. And I think we need to spend some time on the patient to convince them that, for the treatment extend regimen, because a lot of our patients, if the when we focus our counseling only on the structural OCTs, and then we tell them that, it is dry, but still you need an injection. Sometimes we have a loss of compliance from the part on the part of the patient.
Exactly. I mean, we must reach a stage where patients knows that OCT is mandatory.
So do you still follow the PRN regimen for all patients?
The question is to me or to sir?
Both.
You're the speaker. You're the speaker.
Okay. So I almost completely follow the treat and extend regimen, unless otherwise the patient has a issue with economics. Only then I switch to PRN. I've almost most of my patients I do the treat and extend regimen.
Okay, so they are able to understand.
Yes, because the point is that
compliant.
Yes, at the get-go, I lose. See, if I have to lose a patient, I lose them at the very first meeting in my office. The thing is that at the very first instance, I tell them that this is what I'm going to follow. These are the number of injections. A lot of them have gone to other people and they've been told that 3 injections and then we'll see. I tell them that no, it's going to be 6 to 7 injections in the first year and another 4 or 5 injections in the next year. If you want to follow treatment up with me, then you stick around. So I tell them that from the get-go, and that's the reason that I'm able to get a reasonable amount of compliance for the treat and extend regimen.
Thank you.
Okay, so we can move on to the next talk.
Yes.
Yeah.
Thank you, Abhishek. And
thank you so much.
Our next talk will be Dr. Gopal's on the top 5 mistakes in the management of DME. It's a recorded talk since he's not available with us physically.
Thank you very much, KSOS, Dr. Srini, Dr. Thomas, Dr. Sheena, for this wonderful opportunity. Today, I'll be talking on top 5 mistakes in diabetic retinopathy. Let me share my screen. It's top 5 mistakes in diabetic retinal practice. So experience is simply the name that we give to our mistakes. How can all there be mistakes in diabetic retinopathy practice? One is mistakes in the diagnosis. Then we can have mistakes in interpreting the investigations, mistakes in the drugs that we use, the dosimetry, laser mistakes, and mistakes in counseling. I divide these into 5 major heads. Mistakes in diagnosis often appear like this. So we should not have any other differential diagnosis which would mistake. I'll show you a lot of images where you can actually mistake a diabetic retinopathy for something else, right from AMD to PCV to BRVO to CRVO to other diseases. So what happens in diagnostic errors is, you may consider observation in some patients, which may actually worsen. You may consider laser in some other patients because we made a diagnosis like that, but it may not be necessary, or PDT. Or sometimes we may give an injection to a patient who does not require an injection. Or we may not give an injection to a patient who requires an injection. And finally, you may do or you may not do a surgery when indicated or when contraindicated. All these problems will occur once you make a diagnostic error. So why are diagnostic errors happening? Basically because we are using a morphology-based diagnosis. Our own experiences and our own morphology-based diagnosis, it depends on very much on the experience. So sometimes not so much experienced people can make those mistakes, but sometimes very experienced people may also overlook some of these findings. You're looking at some of the yellow spots in the red areas in the blood vessels, which may look funny. And that is the basis of our diagnosis. And sometimes, some images may play spoil spot and you may actually make a different diagnosis. Like in this case, these small yellowish dots are brucines, but some people can make a mistake about hard exudates. And you can see hard exudates right here in an age-related macular degeneration where there is hemorrhages and the choroidal neovascularization here. So when we do a fluorescence, most often we will come to know that it is different, and another thing is in the OCT, you can always make sure whether it is below the retinal pigment epithelium or on top of the retinal pigment epithelium. Diabetic retinopathy being an inner retinal disease, always the disease process is above the retinal pigment epithelium, never below. So here again are some yellow spots here, multiple small hard exudates all around. This could be an AMD or a PCV or a choroidal neovascular membrane, which can be mistaken for a diabetic retinopathy. So in the present, many of these patients may be diabetic as well. Here you can very clearly see that there are no microaneurysms which are leaking. This is a large choroidal neovascular membrane. And in OCT, you can see that all the activity is below the retinal pigment epithelium. So that is a very important thing to do. So when we are looking at a patient, or when we are looking at images, or when we are looking at an investigation, we should always try to find out whether this is above the retinal pigment epithelium or below the retinal pigment epithelium. Hard exudates or hemorrhages does not actually give anything away. So here we can see multiple hemorrhages here, but there is a sensory neural detachment here, and the fluorescence is completely away from that of a diabetic retinopathy. And here also you can see below the retinal pigment epithelium, there are a lot of changes. Subretinal hemorrhage can be sometimes mistaken for a pre-retinal hemorrhage in diabetic retinopathy. Many times I have seen my fellows or my students make these mistakes, but you should see very clearly whether the blood vessels are going on top of the blood or below the blood. If they are going on top of the blood, make sure that this is a subretinal hemorrhage and you are dealing with an AMD or a PCV or some subretinal disease, medical disease. BRVOs, if some BRVOs come like this with a sector completely of hemorrhage, then the diagnosis is fairly simple. But not always does a BRVO present like this. Many times they will present like this with multiple microaneurysms and some soft exudates here and a subtle abnormality in these blood vessels. And as time passes on, you can see that the branch retinal vein occlusion becomes more subtle to diagnose. So here we have, when we do a 90 diopter examination of the macula, you see only some hard exudates here around here, and the vessels look reasonably normal. So those are conditions where you actually can make a error in the diagnosis of BRVO versus diabetic retinopathy. Again, hard exudates here, only hemorrhages, and some maybe 1 or 2 microaneurysms here actual, and only soft exudates. See, these are all patients with hypertension as well as diabetes, and you may make a diagnosis of hypertensive retinopathy or a mixed retinopathy instead of a branch retinal vein occlusion. Can present later phase only with hard exudates like this, and sometimes these fibrovascular proliferations may be so prolific that these vascular blockade can be masked. So all these problems, you can actually make differential diagnosis sometimes difficult. Central retinal vein occlusion in its initial presentation, it's not at all a problem to diagnose it. But later on, maybe after 4 months, 5 months, 6 months, when all the hemorrhages dry up, maybe some of the hard exudates only come up like this, or some of the soft exudates only come up like this, then that is a point of difficulty sometimes in diagnosis. Okay, tributary retinal vein occlusions are only central many times, and so they pose a more difficult challenge in diagnosing. Tributary retinal vein occlusions like this may have only small hemorrhages and hard exudates around in the right in the center, and they may have macular ischemia as well. Idiopathic juxtafoveal telangiectasia often occurs in the presence of diabetes, and many times you can have some pigmentary dots here which are giveaway, and you can see all around there is this whitening, as well as there will be foveal atrophy. So that's a giveaway sign. Always in an OCT, you can find out that it can have foveal atrophy. What about chronic CSR? CSR usually does not pose a problem because it's in a younger population, stress, tension, all those problems, and then there will be sensory neural detachment only without any problem. But the problem occurs when it is a chronic CSR with fibrin and maybe a choroidal neovascular membrane on top of it, etc., etc. Now, here is a typical hypertensive retinopathy grade 4 with a disc edema as well as macular fan or macular star. So when you have a macular fan or star, there are a lot of hard exudates right in the center like this again, which actually can pose a differential diagnosis between mixed retinopathy as well as hypertensive retinopathy per se. Macroaneurysm should be always looked at. But sometimes what happens is that this macroaneurysm may be overlaid by a hemorrhage, and you may miss the macroaneurysm in toto. So you should see that it is in a 55-year-old female, and it will be along the artery, and there will be a central area from which leakage is occurring. So that is how you pick up a macroaneurysm. Radiation retinopathy definitely will have history of radiation as well as multiple soft exudates and sometimes hard exudates right in the center. Posterior uveitis, you have to very clearly see the slit lamp and find out whether there are cells in the anterior chamber, any uveitis in the anterior segment as well as in the posterior segment. White blood cells are distinct from red blood cells on slit lamp biomicroscopy, and you have to pick them up. And sometimes you can look like the leaking disc would look like a proliferative diabetic retinopathy, and there could be a cystoid macular edema also associated with it. Even neovascularizations can be there if there is vasculitis. Toxoplasma, neuroretinitis, Putsch's retinopathy, Best disease are some of the other differential diagnoses which we can look at. Sometimes leukemia also can present with multiple hemorrhages. AION or papillopathy can look with multiple. You can see these are telangiectatic vessels which look just like an NVD. You can see here is a leakage also. But when you look all around, you can see that there is no ischemia whatsoever. There are no microaneurysms whatsoever. All right, vitreous hemorrhage or pre-retinal hemorrhages can occur in other diseases as well with the platelet deficiency, dengue hemorrhagic syndrome, etc. Now, let us look at what are the mistakes in the dose of intravitreal, etc. A very common mistake is, almost all the companies give more intravitreal injection, more volume. And if you inject more volume inside, there could be much higher chances of stroke or myocardial infarction because it reduces the systemic VEGF levels as well. There is a lot of problems with Avastin drug procurement, storage, dispensation, distribution, and injection. So that is again altogether another 10 or 15-minute presentation. Anti-VEGF definitely causes thromboembolic events. So stroke and heart attack, the history should be very well taken. Intravitreal triamcinolone or dexamethasone in glaucoma is again another problem which can occur. So please look at the disc, please look at the pressures before you decide on a steroid. Reduced frequency of injection is a very, very common mistake because you may move into PRN and the patient may decide when to give the injection, and slowly, year after year, there will be 1 line, 2 line, 3 line drop in vision. So upfront itself, you need to counsel the patient that the patient requires this many number of injections. Failure to revise the diagnosis later is again another problem. Now, here's a patient with diabetic severe NPDR nephropathy hypertension. You have multiple soft exudates, looks a moderate NPDR, otherwise 6x6, 6x6. But on fluorescein angiography, you may pick up proliferative diabetic retinopathy. And if you miss it, then this patient will come back to you next time with a vitreous bleed. This is a patient who had some element of edema in the right eye, a little bit in the left eye as well, sensorineural detachment, spongy edema. You could see that there was a bit of cataract. And this patient went for a systemic control and came back after 6 months. The patient's systemic control was also not very better, but you can see the worsening of diabetic retinopathy if you do not treat in the initial 6 months. So if a diabetic macular edema patient comes to us, we need to treat the patient. And here is a patient who has hard exudates away from the fovea. This is a patient whom you can consider doing a focal macular laser and get away with it, or maybe observe. But this patient underwent a focal macular laser, and you can see that the patient's vision improved and the hard exudates have also gone away. Now, this is a patient who had about 15 to 20 anti-VEGF injections still here. And then we went to a steroid, and you can see the magic response in this particular patient. So which injection to give is something that you need to think about. If there are inflammatory signs, if there are microglia, if there are a lot of sensorineural detachments not responding well to anti-VEGF in the first 3 or 4 injections, then you can consider moving to an alternate type of therapy. There's a mild cataract with moderate looking non-proliferative diabetic retinopathy. You did a cataract surgery, a completely normal cataract surgery, and you can see that after 6 months, the patient comes with a bleed. So diabetic retinopathy worsens with cataract surgery. And that is something that we need to tell the patient, tell the physician, tell the cataract surgeon as well, so that we don't miss on these patients after cataract surgery. And before the patient bleeds, you could see the patient, you could diagnose proliferative diabetic retinopathy and start treating. Again, this is another patient who underwent a cataract surgery, and you can see that there is a very rapid deterioration of vision in about 6 months, and you can see the proliferative diabetic retinopathy also coming in. Again, this is another patient with a subsensorineural detachment with macular edema. This is a patient who may be suited for anti-VEGF or for Ozurdex. That is a thing that you have to take into consideration. Now, this patient underwent multiple anti-VEGF injections, but in between he developed a stroke, he developed a foot infection. You can see that he did not get adequate number of injections, and you can see many times whenever the patient comes to me, there's huge edema, and that is a patient in whom there is a tram track appearance. There is a sawtooth appearance in terms of macular edema, and these patients slowly lose vision over a period of time. Tractional papillopathy sometimes can cause decrease of vision. So this patient, if there is tractional papillopathy component, if there is an optic nerve involvement with traction, may consider a vitrectomy a little earlier also. This is a patient who has, you can see that there is a paler disc here, and this is a patient who developed a central retinal vein occlusion in the presence of diabetes. And this patient also developed a neovascular glaucoma later. So what are the pitfalls in practice? One would be a poor diabetic control. Definitely you need to counsel the patient. Economics of injections, the finance of injections needs to be always put close to the heart, and you have to discuss with the patient. Sometimes when the patient doesn't have bystanders, the patient doesn't understand what is happening. And it is always better to involve one more person in his management. most of the patients after a few injections will get a mental fatigue, and it is up to us to actually motivate them to continue further, because if you do not continue with the injections, probably they may have loss of vision. Coexisting illnesses like diabetic foot infection, stroke, heart attack, and renal failure often have a bearing in our treatment, and that needs to be kept into consideration. So the initial dialogue with the patient is very important, and you have to educate the patient and the family regarding diabetes, its continued treatment which is required, and the worsening which can occur if you do not treat. There could be booklets. You could definitely explain about long-term treatment and multi-pronged approach, including diabetic control, exercise, intravitreal injections, laser, and possible vitrectomy. So long-term prognosis with and without treatment is very important to be told. And there are diabetic retinopathy risk calculators which can be shown to us. So always discuss regarding diabetes control and hypertension as well. Quit smoking, regular eye checkups, and make a handy PPT or booklet which can be shown for patient education. Socioeconomic counseling is definitely required, and we should find avenues to help the patient by getting through government insurance or some schemes. So with all this, you have to get the rapport. So mistakes in counseling would be economics versus efficacy. That's a very, very important thing. So we need the patient there. I mean, whatever injection is possible for the patient, you have to take. Number of injections, if you reduce the number of injections, obviously the visual acuity will fall down. The follow-up schedule should be reasonably strict. You can treat and extend, but you should not be just allowing the patient to go away and come back 1 year early. Ischemia versus edema, that is another thing which fluorescent angiography or currently OCT angiography can help us. Scarring versus activity, again, OCT can help us significantly. Correct diagnosis and correct visual prognosis should not have any problem. We have to keep them motivated. You can show OCT follow-ups which show decrease in edema, vision showing improvement trends, and reducing the follow-up frequency by phone follow-up sometimes, and reducing the number of injections over a period of time by reducing into PRN or treat and extend, and changing response, changing injections if the response is inadequate. Considering laser, additional laser is also very important. Finally, I would say that a fool thinks himself to be wise, but a wise man knows himself to be a fool, as told by William Shakespeare. Thank you. Thank you very much.
That was extensively covered by Dr. Gopal. Dr. Giridhar, would there be anything that you'd like to add, sir?
Yeah, I mean, I think the topic was DME.
Yes.
And if you look at diabetic macular edema, I just want to say 2 or 3 things, 2 points. One is, don't treat without looking at the systemic status. That is mandatory. The moment you get a patient, first look into the systemic status, because that's got a phenomenal bearing, especially as far as diabetic macular edema is concerned. Hypertension, coextension, CKD, all these things have got a phenomenal impact on DME. Number 2, look at the rest of the retina, because you must know at what stage of the retinopathy it is. So it's not just treating the diabetic macular edema, but it's also treating the retinopathy. I think these are 2 important, and carefully examine the retina. Look for evidence of PDR. Look for evidence of severe NPDR, which is an indication of a BTDR. So all these things are critical in the management of an eye with diabetic macular edema. Thank you.
Thank you, sir. Very well said. And yes, just because a patient is a diabetic, we need to also look into the other systemic or other conditions which could mimic a DME, like blood dyscrasias or multiple myeloma. Those are the things that also need to be considered, and not to label any hemorrhage or hard exudate or microaneurysm, and don't attribute everything to the DME or diabetic retinopathy. So that comes to the end of the medical retina session.
I would like to add something.
Yes.
We often come across, not very frequently, but we come across situations where you have a DME with a non-arthritic AION, which might be mistaken for a PDR. And then even an FFA could be misleading. So these are situations where you have to go carefully. Otherwise, you diagnose as a PDR, straight away inject once for the DME and start off with your PRP, then you are gone. So make sure that it is not an NVD, it is a non-arthritic AION combined with a DME before you make a diagnosis of PDR and start treating.
Abhishek, anything to add?
Hello.
Abhishek?
Yeah. So, I mean, I think most of the points have already been covered. And, one of the mistakes, I mean, it's all been covered, but I think one of the most common mistakes is that a lot of our diabetics are going for the diabetic checkup, but that even the diabetologists have not checked the renal status. And sometimes your suboptimal response because of uncontrolled renal status can confuse the picture. You may want to shift to steroid, even steroids may not work. So that is also, I think, I always do that. If the patient does not have a serum creatinine blood urea report, I always get it before especially patients that have a neurosensory detachment. So I think that is something that we should, already Dr. Girdhar and even Dr. Gopal Kali said the systemic factors need to be looked at. This was just one very specific thing that, I look at.
Anybody else? Dr. Mahesh?
Muted.
Yeah, he's acknowledged.
Okay.
There were a few questions for Dr. Thomas for your talk.
Yeah.
Somebody has asked whether faricimab is available in India and
Not yet.
Not yet.
We are expecting it anytime this year.
Okay. And it's been doctors' experience that after giving Pagenax, the recurrence happened after 2 months. So what's your experience with that?
For neovascular AMD?
Yes.
Re-inject. If recurrence after Pagenax, re-inject. Recurrence after any drug, re-inject. The only question is whether you want to go ahead with the same drug or change the drug. If it's only one Pagenax, then re-inject with the same drug. If it's after multiple Pagenax, probably it could be a tachyphylaxis. You can switch over to Eylea or something.
I think most of us have experienced that Pagenax lasts between 2 to 3 months. So at the end of 2 months, if there is some fluid coming in, I wouldn't call it actually, a recurrence.
Okay.
That's usually the time that we
plan to give. Yeah. All right. One more question. How has Dr. Prashant is not with us, but I guess anyone can answer. How has Octa changed your practice, and what are the specific indications where you order or you want an Octa without which, or you absolutely require the Octa to proceed or proceed with the management of the patient? Anyone?
Dr.
Divya
is around.
So I'll go first. I don't think there is an indication in NAMD where you cannot treat without if you don't have it. It is always very good to have it because the characterization of the lesion is much better, especially for MNV type 3, even for type 2 and type 1. The characterization is definitely better. You have a better understanding of what you're dealing with. But I don't, see a situation where you just cannot treat if you don't have the Octa, number one.
Well, I'll rephrase it. Any situation in which an Octa would definitely help. I mean, if there is a confusion or the dilemma, an Octa would help in clarity.
I think it's the type 3 CNV, the type 3 MNV, that is much better outlined in Octa as compared to any other treatment modality. The type 3 is best visible with that. And because type 3 has a bilaterality in almost 75% of patients, following up the other eye that does not have MNV as yet, with the Octa will pick up the lesion very early on. And if you can treat it there, then it requires just a couple of injections, maybe 3 injections, and you don't need to retreat it, and there is a complete regression for quite long periods of time. Whereas when we usually see it with a large PD or with a massive leakage, then you need to treat type 3 or RAP lesions for a very long time.
If I had 2 occasions where I feel Octa considerable advantages, one is in the diagnosis of polypoidal choroidal, pachychoroid neovasculopathy. So sometimes it's very difficult to pick up subtle pachychoroid neovascles in both ICG or FFA. Second is very subtle myopic scene. Myopic scene means also sometimes very difficult to pick up, especially as an overlying hemorrhage. It may be difficult to pick up in FFA. So these are some occasions where I feel Octa has got a little edge over the conventional imaging modalities.
And Mactel with the CNVM again. FFA will show just a hyperfluorescence there. So we don't know whether it's because of the telangiectatic vessels that the hyperfluorescence, or there is an underlying intraretinal neovascularization. But then Octa can pick it up. So that is one area where the confusion can be sorted out with an Octa. And another instance where I feel is when there is FA is at widening, and we want to differentiate it from stretch of the FA because of the cyst. So probably you can compare it with an OCT and see whether it is a true macular ischemia, or is it just because of the widening of the FA caused by the cyst. So these are 2 instances where I feel Octa has a little advantage here.
I completely agree. The role, I think, in a day-to-day practice, the role in DME management actually is more than what you would in a NAMD management, because here every single time you don't need to really inject a dye and do a dye angiography. You can FAZ status is an important treatment parameter. I mean, I would say diagnostic parameter in the management of DME, and you can pick that up very easily. So I think I completely agree. In DME management, it is very useful.
And myopic CNV also. Many times there aren't much of intraretinal fluids in myopic CNV. We don't know whether it is clumped there. So that is also, Octa can pick up the CNV better, is what I feel.
Thank you so much. So I think it's time for the next session, which is the surgical retina. So thank you all. I think Dr. Giridhar has left. Thank you, Abhishek, for joining us. And yeah, please stick on for the next session.
Thank you.
So now let's start the most difficult session, that is decision-making in vitreoretinal surgery. So Rahul, Dr. Rahul is moderating the session.
Yeah. So good evening, everyone. What to operate and how to operate is something that we learn during our fellowship. But it's only with both good and bad experience that we learn when and when not to operate. So in this surgical module of KSOS Retina, we'll be discussing about this aspect in detail. So our first speaker is Dr. V.R. Saravanan. He's someone who needs no introduction among retina specialists. He was the first surgical retina fellow from Arvind Eye Hospital, Coimbatore, and has been an integral part of the Arvind Eye Care system since then. He has also done observership at Wilmer Eye Institute, the Vitreomacular Consultants of New York, Columbia University, and the prestigious Joslin Diabetes Center. He currently heads the Retina Clinic at Arvind Eye Hospital, Coimbatore. So we welcome you, Saravanan sir, to talk about this take on when to operate. Over to you, sir.
Thank you, Rajiv. So I'll just share my. Slides visible now?
Yes, sir.
Yes. So so what are the various instances? Cases can refer cases to the VR surgeon for surgical indication. Also, as early sort of indicators for early people who are doing a fellowship in the early stages also help a little bit. So I was mainly asked to talk on these topics, like when do we operate in a patient with PDR, epithelial membrane, macular hole, giant retinal tear, as well as Redgar-Reddy. The first, we'll go to the commonest entity, that is the proliferative diabetic retinopathy. So as we all know, the conventional indications for performing vitrectomy in PDR is non-clearing vitreous, which is one of the most commonest indications. Then we have the traction retinal detachment. Then we have the combined retinal detachment where there's a secondary break because of the traction. And sometimes in patients with extensive iris new vessels, where the pupil is not dilating well. But nowadays, a lot of times in the early NVI, if we can give an anti-VEGF, it helps to direct once it regresses, it can help in dilatation. But a little bit in advanced cases where there is very limited pupillary dilatation, where PRP is a little bit difficult to do, then we also do vitrectomy in those cases also. As regards to vitreous hemorrhage, the initial description was that in media obscuring where it's disturbing the patient's vision. So normally in these cases, you will not be doing where there's subtle floaters or a little bit of hemorrhage obscuring, and where there's a lot of areas to laser, we'll not be doing vitrectomy. But in these cases, so initially when to operate was mainly the data was provided by the BRVS study criteria, which said that we have to wait for 6 months, especially in type 2 diabetics, old onset diabetics. But this was a sort of an empirical time period. They did not have too much thought. Just empirically, they decided that we'll wait for 6 months and see what happens. But 6 months is quite a long time for a patient to go blind, to run around blind. So nowadays, the current trend is they have reduced it to probably 3 months. But again, this is not an absolute indication on when to intervene in a patient with a media obscuring or a vision vision obscuring vitreous hemorrhage. Suppose he's a one-eyed patient where the other eye is blind and is having a vitreous hemorrhage, even for a week or 2 or even 3 weeks, is a big time for him to run around blind. So in these cases, you may want to operate early. Also in patients where there is no PVD, the extensive new vessels, and sometimes other eye you see that there are very, very significant vascular elements, and one eye is totally obscured. Waiting for 3-4 months is going to cause traction, and more surgery may become difficult when you operate early. So in these cases where there is extensive new tissue, especially in the absence of PVD, where the response to PRP is not that very great, in those cases, nowadays we are a little bit more aggressive in going for vitrectomy surgery in these patients. So these are some of the indications. So you have to take every patient case by case basis rather than having a blanket time period like 6 months or 3 months or 2 months. So we have to take each patient on their own merit. Suppose you have a following up a patient with who has already undergone PRP, and there's a few traction elements here and there. And because of partly regressed new vessels is bleeding because of continued traction, you know that already the retina is nicely lasered, and even if you wait, nothing bad is going to happen. In these cases, you may want to wait for some more time. So you take every patient case by case rather than having the time period as absolute cutoff to decide whether it's a non-clearing vitreous hemorrhage. So the time period is totally movable up or down depending upon what you expect in the fundus. What is the patient expectation? Sometimes if the patient is saying, I cannot run around, I'm a very busy person, I'm a professional, I want to get early rehabilitation, then also you can go for vitrectomy. Other indications include where in spite of your PRP, the disease is still progressing, especially in patients with no PVD. This happens in younger patients with no PVD. The tendency for PRP to very aggressively regress the new vessels is not that very great, unlike the old population where there's partial PVD. So in these cases where you feel that in spite of your getting the adequate PRP, the patient is still progressing, you may want to operate. Then we come to the traction retinal detachment. So the conventional indications have been where you have already TRD, which is already involving the fovea. So again, that's an indication where the vision is already dropped and we have to go for a vitrectomy surgery. And next is where the macula or fovea itself is attached, but the TRD is threatening to progress in the coming months or weeks. You feel that the TRD is going to progress and cause visual impairment by spreading to the macula. We don't want that to happen. We want to prevent the foveal involvement. So in this case also where you feel there is progressive disease and the TRD is progressing posteriorly. This is one case where it's actually a one-eyed patient. Other eye was operated and failed actually. So we are here, you can see that there's a superior, even though it's not visible clearly here, you can see that superior traction is causing a TRD, and the TRD is extending into the below the superior arcade towards the macula. It's just about across the superior arcade. So because other eye has lost vision, I didn't want to wait for this patient to progress. So I'm taking it up early. So the confidence of operating on such very visually patients who have very good vision mainly has happened because of the advances in instrumentation, advances in surgical techniques, advances in viewing systems. So all these things have made us much more confident in dealing with patients who have got either 6/6 or 6/9 or 6/12 vision. Unlike olden days where we used to, during our fellowship, we used to wait for the vision to drop, then take it up, because the outcomes of visual outcomes of the surgery was not that very great. But now we have come a long distance from those time, and we have a very good prognosis. So we are much more confident in taking up patients with very good vision. And next is the combined retinal attachments, where even if phobia is not involved, you have to treat them as acute regardis, because they can progress very, very fast. So once you diagnose the combined mechanism RD, whether it's involving the phobia or not involving the phobia, it's an emergency situation, and you have to do immediate surgery, so that because the progression of RD becomes very fast because of the presence of break here. So you can see this is a TRD, and I'm trying to drain the fluid through the break. Then comes the vitreomacular traction, where the condensed both the neovascular tissue as well as the condensed posterior hyaloid phase can cause traction on the fovea. So when this is causing vision loss, again, this is mainly diagnosed by the OCT, because clinically it is very difficult to pick up the subtle traction, subtle elevation of the retina. So best is to do OCT in patient where you have unexplained vision loss, and take them up for surgery as early as possible. The VMT can be focal, like you see in the left side photograph, or like a diffuse or a broad-based vitreomacular traction, like in the right side photograph. So whatever the case, if you feel that it is disturbing his visual outcome, better to take them up for surgery as early as possible. And again, Dr. Gopal talked about this, the traction papillopathy, even a lot of it's a sort of a slightly controversial diagnosis where everybody does not accept this as a diagnosis. But in case you feel this traction is leading to decreased vision, there are some reports, like one of Dr. Shukla from our hospital in Madurai, he had published a report of resolution of traction maculopathy successfully after vitrectomy surgery. In case you feel that this is the reason for both the peripapillary and disc edema and macular edema, you feel this is the cause, then you can go for treatment like the traction maculopathy. One more thing is the subtle nasal traction. This is commonly missed by even established VR surgeons. Here you can see that the pseudo pallor of the disc, it's not a true pallor, it's a pseudo pallor because now it's covered by a layer of retina. Look at the architecture of the superior and inferior arcade. You can see it's nasally dragged. Look at the curvature of the arcades, and look at the disc, which is pseudo pallor, and look at the fovea. Normally it's 2.5 disc areas from the fovea situated slightly further away from the disc margin. But because of the nasal drag, the disc and fovea are very close. And the pseudopallor, because the retina is covering the, so you look at the OCT, you can see this is the area where the retina is covering the disc, so it's causing a sort of a pseudopallor. But the fovea itself is attached. You don't get misled by this foveal attachment. This will cause slow onset vision loss. Initially, it will be 6/9, 6/18, 6/24. So if you operate late in the course, the foveal anatomy will never come back. So it's best just to, once you identify this, that the fovea is getting dragged nasally, the disc is getting covered by the retina, try to intervene as early as possible to prevent vision. So unlike the BMT where the vision drops immediately, the nasal traction or a papillomacular bundle traction is a very slow onset. So try to look for this and pick up early and intervene early in surgery. So right now we are much more aggressive in treating, advising surgery, because we feel that stitch in time saves time. Meaning, we feel that looking at the patient today, you feel that by down the line, in a few months or a few weeks, he is going to need surgery. Better to intervene as early as possible, because as the course progresses, the traction becomes much more severe, retina becomes much more thinner for continued traction, and lace also will create a lot of anchoring points. So operating a patient who was undergone PRP and where you waited for the retina to become thin and atrophic, it becomes difficult with a lot of complications. Better to intervene as early as possible. Other indications are when you are not, diabetic macular edema is there and you're not, it's not responding to your conventional injection, whatever injection you have tried, and all the injections are failing. Then you may want to do ILM peeling in these patients. And then the taut ILM syndrome. Look at the configuration of the edema. So normally a DME is like a pyramidal shaped, like a mountain shaped. But when you have a flat surfaced macular edema, it's either because of a taut ILM or because of a ERM. So in these cases, vitrectomy will only help. Otherwise, injection will not help in these situations. So taut ILM syndrome, where you have a plateau configuration of the retina rather than a pyramid mountain configuration, is indication. This is one more case where the injection did not work. The right eye was treated with the injection, the left eye went in for vitrectomy. At 6 months, you can see that there is considerable resolution of edema. But it's like the surgery is not a first-time therapy for non-tractional edema. You should keep that in mind. This is one more case of non-tractional edema where injection was not working very well. So I did vitrectomy. So keep in mind, even though I'm showing pictures, ILM peeling as a treatment for a non-tractional DME is not a routine thing. We only reserved for the last resort. And sometimes epiretinal membrane maybe be the cause for persistent or intractable DME. In these cases, ERM pairing will help to resolve the edema. And last indication will be like asteroid halitosis, where there is considerable media opacity, whatever cause, and you're not able to do your PRP properly. Again, it's indication for vitrectomy. Another rare indications are where you have a glaucoma secondary to the blood, Gosel glaucoma or hemolytic glaucoma. We want to clear the blood. We want to deprive the or denude the depot in the vitreous cavity. Coming to the epiretinal membrane, these are my indications for operating on ERM. So I don't take vision as an absolute criteria. For me, even 6.6 or 6.9 or 6.6 parts, whatever, I don't mind. So if you feel that the patient is complaining of vision loss, he comes to me saying that my vision is dropping, I operate. Or the patient says that my vision is good, but I'm seeing distortion, my letters are a little bit dancing, then also I'll operate. I operated even on a VR surgeon who's got 6.6 vision. I operated because he was complaining of distortion. He was having difficulty with his surgical, when he was performing surgery, he was not comfortable. So we did the surgery for him, even though he had 6.6 vision. And sometimes in old people, they're not aware of vision loss because other eye is good. So suppose in January, I'm seeing him with 6.9 vision, and now he's coming at in July or August with the 6.18 vision, where I have documented. I'll try to counsel the patient that your vision is dropping, rather than taking them up after the vision has dropped, because recovering lost vision is not very easy. It's better to operate them in the much more in the earlier stage where the vision is already still there and not dropped. So these are my indications for operating on epiretinal membrane. So absolute vision is not a criteria for in my clinic. Macro holes, ideally, the best visual outcomes are attained by macro holes which are less than 6 months old. But a lot of times you say that old people did not give a proper history. But in our clinic, I'll tell that if it looks like a chronic hole because of degeneration in RP, I tell them that the vision improvement may not be that very great. And I'll give the choice to the patient. If he says, let me try, I'll try. If they say I'm not very keen, I'll not push them. If it's a fresh case, I'll try to push them so that the vision, the child has a good chance of visual improvement, and ask them to go in for surgery. Nowadays, because the hole size is not a big issue, because there's so many tissues to stuff into the macular hole. It can be ILM flaps, it can be retinal autografts, it can be amniotic membrane, sometimes lens capsule. So those things, we have the choice of getting a much higher macular hole pressure because of all these newer advancements in techniques. As regards to giant retinal tears, if it's like a fresh tear where there is no fluid or very limited fluid, we will try to do a barrage laser to connect it to the ora. But if it's already detached, most cases which come within the fresh cases where there is not that very significant PVR, where I feel that I can unfold the retina and attach it. So those cases I'll always do. So I don't usually have the chronicity. Whenever the chronicity is there or very chronic arteries, I tell the patient that the chance of visual recovery is very poor, and I try to dissuade them. But if they still feel they want to give it a try, I'll advise. So I leave it in chronic cases where I feel that visual improvement is not going to be that very great. I give the choice to the patient, let them decide. In fresh cases, I try to push them as much as possible to go for early surgery. So again, as I told you, I don't mind operating in chronic cases or very bad cases. Also, this is a trauma case who had a 360 GRT. You can see a totally cauliflower retina, whereas full GRT. So we are doing a bimanual technique to peel this. This patient got back up approximately 3 to 460 vision. So I give the choice, whatever the choice to the patient, where I feel the prognosis is poor. If the patient decides, I'll not hesitate to do surgery. Wherever I can feel physically, I can unroll the retina and attach it. In RRD, the ideal case will be a macula on or a very fresh RDs. And if it's a traumatic RD, I will not take no PL as a criteria, because a lot of times you see that the patients who present with no PL vision after surgery can get back considerable vision. There are a lot of publications on this also. In a normal RRD, no PL, I will not take it up, but in a traumatic RD where there's no PL vision, it's not a contraindication. So no PL is not a contraindication only for severe ocular trauma. And even in closed funnel RDs, I will not hesitate if I feel that I can attach the retina. So when the prognosis becomes poor, I don't make the decision. I give it to the patient. I tell them that the prognosis is not going to be that great. If you're very insistent, I'll do the surgery. These are my criteria for performing on very chronic RDs. I'll stop here. Thank you.
Thank you, Dr. Sharavanan, for that wonderful videos and the talk. And I think it's difficult for, it's going to be difficult for Dr. Mahesh because I mean, the indication for surgery is really wide. And I would like to ask you, like, in cases of diabetic macular edema, you were mentioning about non-response with the anti-VEGF for intravitreal injection. So, like, when do you decide? Do you keep a cutoff vision as any criteria, or what is your threshold?
Vision, unless it's a very like other eye is normal, my intent, I mean, my aggressiveness becomes less, especially if the patient has got 360 vision in one eye and the chance of improvement is very poor. Another has got 618 or 612, then I would not be too pushy. But if that is a better seeing eye, we have to get the edema down so that we can, even sometimes you may not feel the difference in the visual acuity, but patient will have subjective improvement. In these cases, one-eyed cases, I tend to be a little bit more aggressive. I'm not talking about the surgery, but the treatment as such. But non-responders, we did a study as a primary treatment for diffuse macular edema in one of our postgraduates. They did a thesis. Unfortunately, the results were not that very encouraging for vitrectomy in a non-tractional edema. I use it only as a last resort because our own experience in resolving the macular edema is not that very great. We did a short series of around 30 cases, and only 50% to 60% had a resolution of macular edema. Other patients have only part resolution with no improvement. So I would not advise vitrectomy as a primary intervention for non-tractional DME, definitely not.
Okay, thank you, sir. And as sir mentioned, like in cases of PDR with vitreous hemorrhage, maybe like as he mentioned, like even if there is a vitreous hemorrhage, if the patient may be the pre-treatment condition, if the patient already had undergone a PRP, good PRP, then maybe like we can like wait the threshold. If the patient is like untreated, then maybe we tend to take the patient a little earlier.
Tendency among people to have this 6 months or 3 months as a cutoff period. What I am saying is don't keep time as a cutoff. Take each patient as a single case. Don't try to have a blanket protocol. That's what I was trying to say.
And one more thing, in cases of PDR with this nasal traction or with the traction papillopathy, so what is your threshold, or do you decide on treatment when you see the patient first time, or do you keep a follow-up of this patient to see whether there is a worsening?
In disc traction, I have not seen many cases where disc traction has caused a vision loss. So my traction papillopathy itself, I'm not too aggressive unless I feel that it is the cause. But for PMB traction and nasal traction, I am very aggressive. The reason is that once the vision drops to a considerable extent, we cannot get back the vision. And the anatomy never comes back to normal, even after surgery. The shortening of the fovea is the distance between the fovea and the disc that never comes back once it reduced. So once I identify, I try to push the patient for surgery to prevent slow onset of vision loss. It will take 6 to 8 months for the patient to lose vision. By the time he says that I want to operate, that time we'll not be able to get back his vision. So I am a little bit more aggressive in a nasal traction or PMB traction.
Thank you, sir. There is one question from the audience, like how long do you wait to operate in traumatic macular holes?
Traumatic macular holes, approximately, there are few studies showing that approximately 70% of the holes will close by the 3rd month. So I do a sequential OCTs every month. If I feel that the diameter is getting smaller and smaller, where the flaps are getting flatter and flatter, attaching to sort of a U-shaped configuration. If there is progressive betterment, I wait. If there is progressive detriment, I immediately operate. But ideally speaking, you have to wait for at least 2 to 3 months before you decide to operate. That's what the conventional teaching says. I actually go by the serial monthly OCTs to see if it is increasing or decreasing.
Thank you, sir. Dr. Rahul?
There's also one question from the viewer regarding how would you decide about the retinal patch graft and how do you keep it in place?
So patch graft, I never use it. Primary modality. Patch graft, retinal autograft, I don't use it a primary modality. So we usually go for either a reverse flap or a temporal flap. And if that is not working, if the first surgery is failed, then only I go for a patch graft. Also, I do patch grafts, retinal autograft in patients with high myopia, where the chance of hole closure is there. And also sometimes I do in high myopia with the RDs. I do a peripheral retinectomy and take a piece and put it inside. So normal cases, I never use retinal autograft as a primary modality. I use it in only failed cases where the hole size is more than 1,000 or 1,500.
And sir, in cases of vitreomacular traction, if after inducing the PVD, you're very sure that there's no macular hole, do you still go ahead with the island peeling, foveal sparing island peeling? Or
if you have if I successfully release the traction without a hole formation, I don't do ILM peeling. If I feel that I don't have an intraoperative OCT, so I cannot ascertain. If I have a doubt, then I go for ILM peeling.
foveal sparing. Yeah. And so, in the cases of ERM removal, many times we do see some amount of this component of inflammation there. So, what is like the criteria where you decide after post-op during the intra-op itself you plan to inject steroid, probably Nosrix or something like that?
It is that in all cases of ERM with significant spongy edema, it is the best to go for a primary sitting itself, go for a Orthodex. But in our hospital, because we cater to mostly a low-income group, the surgery cost becomes double. I'm a little bit difficult for me to convince people to get Orthodex, but given the choice, I would go for I will give injection Orthodex for all cases with significant macular edema, because the edema takes a long time to subside in these patients. So that's my preference, but unfortunately, I cannot implement in our hospital settings.
So have you tried dexamethasone, something like that? Like not intravitreal implant?
So in a vitrectomized type, the longevity of tricot is very poor. Hardly it stays for 2-3 days, and the efficacy may be not more than a week. I'm only talking about dex implant in ERM. I'm not talking about IVT. I'm talking about only dex implant.
So anybody else has any question to Saravanan sir?
I think there is one more question. What is the prognosis in macular holes in PDR? Any change in technique? Is from.
As I told, the chance of macular hole closure in PDR is a little bit less than conventional macular holes, routine macular holes, because one is the retina is very thin and atrophic, plus they are releasing a lot of tractional elements. The retinal anatomy does not come back to normal early. So in these cases, the inverse ILM flap is, if it's small holes, you can do better to do inverse ILM flaps. Routine conventional ILM peeling has got a higher risk of failure in PDR cases.
Okay, I think, thank you so much, sir, for that wonderful talk. And I think we will have more discussions after maybe the next talk. Over to Rahul.
Yeah. So after that enlightening talk, there's a difference between giving up and knowing when to stop. So the next speaker is our very own Dr. Mahesh G. He's an alumnus of Trivandrum Medical College, following which he completed his surgical retina fellowship from Shankar Nethralaya, Chennai. He has been working with Giridhara Institute, Cochin for over 2 decades, now which he currently leads. Interestingly, even in his busy schedule, he has completed his postgraduate diploma in medical law and ethics. So I find no better person who can talk about when not to operate. Over to you, sir.
Thank you. Is my screen visible?
Yes, sir.
Audible, no? Okay.
Yes, sir. Yes, sir.
So this is, yeah. So my talk is when not to operate in pertaining to VR surgery. This is not a debate with Saravanan. Saravanan is one of the best surgeons in the country. And whatever I am going to tell, Saravanan also will agree at the end. This is not a debate, but these are some other angle where I would like to address this issue when not to operate based on some other angle, not the technical thing. So doctors, this I got from the WhatsApp. Doctors, especially surgeons, are simple souls. Their basic needs are OT, Kapada, and Makan. So this was I got. So I thought, correct. We are all very happy with doing surgeries. And there are ever expanding indications for VR surgery, like the all sizes of macular hole. Actually, when we were doing fellowship in '99, there was not many macular hole surgeries were done at all. DME, all the indications Dr. Saravanan told, myopic traction maculopathy, ROP, even vitreous floaters. The cause, the indications are expanding just because of advanced technology, the technology advancements, and demanding patients and aggressive surgeons sometimes. That I will tell you why. The basic principles of medical ethics includes autonomy, beneficence, non-maleficence, confidentiality, and justice. These are the 5 pillars of medical ethics. Of this, you just see the non-maleficence. We should do no harm to the patient. It is called primum non nocere. There is no surgery with 100% success rate. Latest technologies, I am talking about PDR mainly. at least have 10% or 5 to 10% failure rates. And all of us know that in one-night patient, this makes a huge difference. So you have to do a risk-benefit analysis in PDR surgery and then only decide on surgery. As the saying goes, a surgeon in his first 10 years of career learns how to do a surgery. In the next 10 years, he learns when to do surgery. And the last 10 years, by burning hands, in a lot of cases, he learns when not to do surgery. So this is something that I am going to highlight with few case scenarios. This is a case, PDR surgery is always challenging because when we look at the patient, we may be seeing for the first time. There are cases that need surgery without any doubt. Acute combined RD, progressive tractional retinal detachment, or non-resolving. All indications Dr. Sharavanan told. These are cases which require surgery without any doubt. And there are some cases which remain stable or worsen very slow, like some premacular fibrosis with focal traction, or some chronic TRDs which are there for many years, which will not worsen. In these cases, your intervention may suddenly reduce the quality of life or quality of vision of the patient. For example, one-night patient, end-stage PDR with ambulatory vision, one eye already lost. So these cases, if you ask a detailed history, they may be telling more or less like this for 3-4 years, but they have come with hope that I will recover more vision. So it may be very deceptive if you take it up for surgery. Preoperative vision of 2 meter may be better than postoperative vision with oil and a better anatomical macula and retina. So these things you have to consider. Take a detailed history from the patient. And there are some things like macular ischemia and optic atrophy, which you may miss during your busy schedule when you decide for surgery for PDR. The findings may be out of proportion to the vision. The vision may be out of proportion to the findings. Just think about these two things. We miss optic disc many times. When you do surgery, either you should improve the patient's condition or you should prevent further deterioration, right? These are the indications. So there is no point in if you are satisfying your ego and just not giving any benefit to the patient. So this is one case. Already one eye is NVG. Other eye, somebody has sent. Other eye had 6/18. Left eye is blind, NVG. So no acute vision problem. Somebody has referred. So this is the thing. So he's having 6/18. I know that this traction is gradually going to worsen over many years. But suppose you do a good detailed surgical removal and then put oil, the vision may be 2/60. And the patient may be eternally unhappy in many of these cases. And especially if the fibrous tissue is extending to the extreme periphery, it is very difficult to give even anatomical success in many cases, like this chronic changes in the retina, schisis and all. So these cases better to discuss see once or twice again and again, and then only decide surgery in this case. Sometimes it may look very nice, but you will see all the sclerosed vessels and patient has a chronic cases, chronic disease. This also you may decide surgery not in a hurry. So will you be able to remove the membranes completely? And remember one thing, iatrogenic outbreaks outside the equator with persisting traction and inadequate membrane removal means lost case. So you will have ultimately PL or no PL vision with oil inside. Every one of us will have this experience in our life, but we would like to forget it. What will be the final vision possible with oil and after oil removal? You have to think these things and then only decide. So why we fail in PDR surgery? It is actually, we don't have to, it should not hurt our ego. Surgeons cut out everything except the cause. It's absolutely correct because we are fighting against an ischemic avascular retina with PDR. So we may fail sometimes. There is nothing to admit that. This is another case. Case 2 is, I think, is different. Accidentally defect. This is another indication. Accidentally detected defective vision, 6/60. And this is a chronic ERM. All of us will remove this ERM, right? So, but the problem is the visual outcome may not be very good. With the quality of vision may be very poor, in spite of, because there is totally disorganized retinal layers. So this is a chronic thing, accidentally detected. So these cases, if the patient is very, very, he wants to get maximum, It's better not to touch. And this chronic ERM, the quality of vision post-operative will be quite bad. Consider the age, other age status, and demands of the patient. It is difficult to satisfy demanding patients. Discuss the real outcome that is possible with patient and decide. Remember, the OCT improvement will not please all the patients. They will be cribbing and cribbing. And all of us have very bad experience with ERM cases where the patient is eternally unhappy. So lamellar macular hole is another thing. There are two types of lamellar macular hole, tractional and degenerative. In a degenerative form, there is something called lamellar hole associated epiretinal proliferation. This is something that we usually don't operate. These are two things, lamellar macular hole. In the second one, the first one, there is an epiretinal membrane. You can remove it, maybe better. But the second one is lamellar, degenerative types of lamellar macular hole. The natural course of lamellar macular hole is not bad, and so the surgical treatment is little questionable. So non-tractional lamellar macular hole may not be very good indication for surgery. So LHEP surgery outcomes are not very encouraging. So this is one thing that I observe. So this is one case which was operated pre and post, and you can see that actually patient was not at all satisfied in this case. So full thickness macular hole, when not to operate. Now we can operate any full thickness macular hole because you can stuff a lot of things inside. So, but you have to see the patient as a whole and decide when to operate. All of us do say, leave it. We'll forget about that. If the other eye is normal, especially in an elderly person who cannot maintain prone with systemic problems, and it is chronic with a lot of large macular hole. With even if you close it with all the stuffings, paneer stuffing or any other chicken stuffing, any stuffing, it will not close. It will not improve the vision too much. So if the other eye is absolutely normal in an elderly, I may not operate. Then traumatic macular hole, yes, you have to wait for a little. Already that question has been asked. I also follow what Dr. Sharavanan said. A couple of months, 1 or 2 months, this is flattening. Forget. Then there is no need of surgery. Then some cases will have choroidal tear with macular hole. These cases are not going to improve anyway. So see the other surrounding area for choroidal tear and optic disc pallor, optic atrophy or something. Don't do unnecessarily surgery. When not to operate in RD is another question. We do operate in most of the cases, but there are some bad outcome indicators. No PL or suspicious PL in a chronic RD, I may not take. Hypotony, very bad because it may indicate cyclodialysis cleft, rubeosis or subretinal cholesterol deposits in an RD. That means patient is having a long-standing problem, probably in Ayurveda treatment. Or we do come across a lot of such patients. So we don't operate these cases. And but no PL is not a absolutely no, because we do try on bilateral fine cases and some kids, and usually we try on sympathetic grounds, and then some cases we burn our hands also. But as Dr. Sharavanan said, trauma case no PL is not a contraindication for surgery. This patient had a upper sclera rupture with no PL. We did surgery after 15-20 years or 15 years, I think. He is having still 2 meter vision in this. So the basic principles of surgery, some wounds are made worse by treatment. As we see, it had been better not to touch them. So this is one principle. In conclusion, there are some cases with natural course of treatment may be little better than our surgical results. There are some cases we will not be able to give any improvement in quality of vision and quality of life. In those cases, just take a second look and take a second opinion if needed with your colleague in your hospital or some other hospital. Once you touch the eye, you are liable for the status of the eye, whatever it may be. So these are my points. Thank you. Thank you.
Very super. Very nice comment. I didn't put LHEP in LHEP because I have a very low threshold for touching eyes with LHEP. What Mahesh said correctly, LHEP is one case where we are very distant to operate. That's why I didn't put my indications for doing surgery. So it comes in the against. But otherwise, very nice.
Actually, like I said, these are practical things that we come across. All of us, every day, we will think, why the hell I took this case? All of us will be thinking. Because when we see our own patients on a long follow-up, we are getting a very good follow-up with our own patients. They keep coming back. So some cases I send to Saravanan and Saravanan will give on advice like that, so that they are happy. But these are, I don't know whether I did justice to the talk by not touching the, the surgical thing. It is.
Few things I tell to my fellows when they have confusion on whether to how to decide what to do and all. So I ask them to answer two questions. Either first question is, I'm going to make the patient better. So if the answer is yes, you operate. Second question is, I'm going to prevent him from becoming worse. If also answer is yes, you operate. If both the answers are no, then there's no point operating on these cases. So these are the two questions I tell them to. When you have a doubt, ask these two questions. Whether by doing intervention, I'm going to make the patient better, or I feel that it's going to become worse and I'm going to stop it by intervening. The answer is yes for either of these questions, then you can go ahead. If the answer is no for both the questions, just take your hands off the patient.
Absolutely. Absolutely.
Mahesh sir, there's one question. I would like to ask one question. Many times, you see a case, you have decided that there's no point of doing anything, any intervention for this patient. So when you tell the patient that it's best left alone, is it medico-legally necessary that you should get a second opinion? Or is it like your word is fine?
Yes. I'll tell you that aspect. See, having different opinions or even differential diagnosis for your patient is not a medical legal issue. Because one case I may feel he will improve, some other person may feel. It doesn't mean that that there is a famous verdict by Supreme Court of India, Kusum Sharma versus Batra Hospital. The Supreme Court has clearly told that having different opinions, rational opinions for a same case does not mean one is negligent, the other one is not negligent. So, as you said, if you say there is no point in operating, and somebody else told you this should have been operated early, why you didn't operate? So that always you can ask for a second opinion with some seniors or some other colleagues. So that will help you. Otherwise, they cannot go for a medical legal case just saying that your opinion was different from others' opinion.
Can I intervene for a minute?
Yes, sir.
Yeah.
In such cases where I believe that I won't be able to do a good job, I never tell the patient that this won't improve. I only say, in my hands, you're unlikely to get a good result. And I stop with that.
That is too polite, man, Thomas. You are too. That's not a good idea. You can meet some experts, more expert than me. That's a good idea. Any other questions?
Yeah, that was a very wonderful talk, sir. As usual, because it's the experience which talked, and it's a good guidance for many of us. And so have you felt like any time, like maybe I should have operated this case earlier, especially with regards to diabetic retinopathy, and did you change anything in your practice, seeing any of the cases or something like that from your experience?
That also is true, because sometimes PDR cases, when we, after 3-4 sittings of laser, then we go for the surgery, it will be very difficult to remove the membranes. So I always feel that this would have been removed earlier. So after laser, surgical removal is difficult because each laser mark will anchor the retina, and you will create multiple breaks when you remove the membrane. So it becomes and fibrosis is more after laser. So I feel that. And another thing, probably like vitreous hemorrhage, sudden vitreous hemorrhage. In it, we'll do a B scan. Then there is no RD. We will ask them to come after 1 month. Then after 1 month, there will be RD. Then I will feel, okay, we went as per the indications, but we would have intervened earlier. So like every day we will see something like this. But always, yeah.
In countries, they operate for even very small lesions also. We are only doing it very late. We go to US and Europe and all. Their threshold for surgery is much lesser than even for a small vitreous. Immediately they have any fibrous tissue, they immediately operate. So we are actually lagging behind. They are much more aggressive. Mainly because
that is because they have 10 OPD, 2 cases. Not like you, 100 OPD and 10 PDR cases a day. Okay.
Probably insurance also plays a factor here.
So that's what coming to that point actually. So do you, I mean, like after seeing many of the cases, sometimes you feel like that, why do you have to do repeated laser when you see these kind of tractions, which is outside the macula? And why don't we take up these patients for early surgery? So, I mean, like, have you changed your kind of indications?
My clinic, I think we are intervening much more early. So I look at the patient. If I feel that there is a significant risk that down the line of in a few weeks or months he is going to need surgery, I try to intervene early, because the failure rate and complication rate becomes much higher when, as Mahesh was already putting it up, after laser everything becomes much more difficult. So if I feel that, I try to convince the patient. The patient is convinced, I'll take it up for surgery. I feel the early surgery outcomes are much better. Plus, it's less intense for the surgeon also. We are the whole heart rate up. We lose so many minutes of our life operating. Our lives become shorter. The surgery times increases.
Yeah, Divya, that another thing that you are right. Actually, there are some people, every mild vitreous hemorrhage due to partial PVD, they will give more laser, and ultimately you destroy the whole peripheral retina. I think what I am doing now is 1, 2, or 3 sittings of scattered laser, and if it is worsening still, it is better to operate at that stage rather than keep on lasering, and making patients' peripheral vision also bad, and your laser does a lot of harm in these cases.
And so you showed one case of ERM in a late stage where you told like you won't operate. So in early stages, when do you say that I am not going to touch it? Or when do you decide?
Actually, with experience, I'm the OPD experience I'm telling. There are some cases where it is grade 1 ERM, which was detected accidentally by an OCT done elsewhere. A lot of people come like that. Somebody found that there's an ERM and referred, but it will be 6/6. They don't have any complaints, and those cases I will not operate. Grade 1 ERM foveal contour is normal. These sort of cases. But as Dr. Sharvan said, symptomatic patients, even if it is 6/6 or 6/9, we can take it on. So, and the other indication is progressive deterioration of vision. Next, after 6 months, if you see the worst vision is progressive deteriorating, you have to. So, accidentally detected grade 1 ERM by somebody else, I will not take.
There is one question from audience. Please share your experience in operating for ERM associated with vascular occlusions.
Usually, these ERMs are a little bit more vascular. The chance of bleeding is higher. The chance of more adherence, deroofing of CMEs can also happen. So you have to be a little bit more careful, take a little bit more time. The posterior face is very stiff in these cases. So that rather than using suction to induce PVD, you may have to use sharp instruments like a pick, retinal pick, to make a small nick. So you have to we should try to minimize the tractional force on the fovea when you are doing your PVD induction and cutting off the surface hyaloid. So then you have to do slow peeling. If the membrane is not coming, I usually go for ILM peeling to release. Sometimes the ERM is more adherent at the roof of the fovea. So if you're trying to use a little bit more force, you can cause deroofing of the macular foveal whichever is there. So in these cases, if I feel it's a little bit stiff, I go for ILM peeling. And so once you peel the ILM all around, and the last point of release should be the fovea. So if you release that way, the chance of causing a iatrogenic macular hole becomes much lesser. So the two things you have to take care. Inducing a PVD, don't use forceful suction because it can cause deroofing. Second is, if the foveal adhesion is very strong, go for ILM peeling to release the fovea. These two are my tips, I will say.
There's one more question. There's one more question pertaining to the same. So please go ahead.
Yeah. No. If the macula is very ischemic, just for removal of ERM, I will not do any ERM removal in a RVO case. Like already that half of the macula is totally ischemic, patient has very poor vision to begin with. So if your own patient is coming back to you, it is easy to judge. But always if there is a vitreous hemorrhage or TRD with vascular occlusion, like Dr. Sharvan said, we have to do.
Divya, there are a couple of questions on your WhatsApp from the audience.
Yes, so there's one more question from the audience. Saravan sir, this person had a ER removal had during for TRD surgery had a macular hole. So when would you intervene?
Macular hole with the ERM.
Basically for TRD surgery, operated and post-op noticed a macular hole. So when would you intervene?
Okay, so again, it comes down to the what do you expect to vision, whether you feel the vision will improve after successful macular approach. That should be the question to be answered. The already macula is very ischemic and very chronic TRD, and you feel that the closing the macular hole will not lead to any beneficial effect because you're going to do a second surgery. And as I told you, the success rate of macular hole surgery in a PDR case is not that very good. So you have to take this into account. I would do only if I feel that closing the macular hole is going to contribute to his visual improvement. Otherwise, I'll try to discourage the patient from going to for surgery.
I think there is one question to Saravanan sir. For macular hole, why did you do temporal patch graft? How do you decide regarding the retinal patch graft and how do you keep it in place?
Okay, so temporal, the theory was that the Mikloska, the original proponent who devised the inverse flap technique, so they showed that the mere act of peeling the ILM causes this Donfell or disruption of the outer nerve fiber layer, and there is some sort of Muller cell damage also. So they tried to limit the amount of ILM peeling by doing a temporal flap. So they thought they proposed that tangential traction from the temporal retina was more critical than the nasal part, just like a hinge door technique. So you take a ILM flap from the temporal side and flip it over the fovea to cover it. Rather than stuffing it inside like a hinge door, you just slip it and close it. So under air, you just have to stroke the flap of ILM over the, so once you peel the ILM from the temporal side, and during fluid, after you complete your fluid exchange with a soft tip or with your finesse loop or with your DDM diamond-nested membrane scraper, you just stroke the flap to cover the fovea. That's what you do. So temporal flap is easier to position than a routine inverse flap or a routine ILM free flap. So it's much more because you have a larger flap and does not get lost easily.
So what would you take on making a superior, like the taco technique? What would you take on making superior flap? Because that would be easier to maintain position, right?
That is position. The Mikloska, they proposed that the temporal tangential traction was the more important aspect where the whole, the pathogenesis of the whole. So they proposed that the temporal aspect was the more tractional component. So releasing the temporal component was enough to close the hole. That's what their theory. But you are free to do, like if you see the Dr. Atul Dhawan from Agarwal's hospital, Chennai, used to take only 1/4 of the, normally the Mikloska, they used to take 180 degrees. Used to take only a circle, very small flaps to cover. So he used to take it from, I think he was also taking from the superior temporal aspect. So he was showing success in his cases also. It's up to you to decide, but the proponent's theory was this.
So I think no more questions. So, so to conclude, maybe with from the experience of experts, actually, we understood that it is basically when you decide to operate or not to operate, it is to look at what the patient demand or what is their requirement. And as a surgeon, what is that you are going to give the patient. So these two factors are very important when you decide on surgery on any patient. And we cannot generalize even any disease to all the patients, and it should be patient-wise. Actually, we should decide whether to operate or not. So thank you, Dr. Saravanan and Dr. Mahesh for having that wonderful session and enlightening all fellows and all our new surgeons to decide on like what are the steps or the tips to look for when you operate on any patient.
Thank you, Divya. Thanks, Mahesh. Thanks.
Thank you, Saravanan. Thank you, Mahesh. I think Dr. Rajesh and Rajasri can take over the proceedings. Dr. Soumya expected to join anytime. If he doesn't join, then we can probably.
No, I'm around.
Yeah. Okay. Welcome.
Yeah. Thank you.
Having had a vast coverage of retina, we move on to the next session on uveitis. The chairman of the session will be Dr. Rajesh. My proud privilege to invite Dr. Soumya Basu for his next talk. Sir is the head of uveitis at the prestigious L.V. Prasad Eye Institute, Hyderabad. His areas of research interest include immunopathogenesis of ocular tuberculosis and infectious uveitis. He has many prestigious awards to his acclaim and over 110 publications and book chapters. Over to Dr. Soumya for his talk on diagnosing uveitis, what to test and how much to trust.
Thank you very much. That was a nice introduction, and I'm glad so many of you are here, leaving behind the Wimbledon men's final and watching the wonderful session that has been going on. So I'll get started with the talk, and this one is a little different from the ones that you might have heard when people talk about investigations in uveitis. I'll give a brief introduction to the what to test part, but most of this talk is about how much to trust. So let's get started. So what I'm going to cover is why do we test and how best to use the tests that we do, and a concept of pre-test probability. What we'll not do, and what I strongly discourage to all our trainees, is the idea of uveitis workup. And you will see in this presentation why the workup idea is not a good one. This is the 4-page document from the American Journal of Ophthalmology 2013, which I strongly advocate to everyone who has the slightest contact with uveitis in the clinic. This is fantastic, and the kind of introduction it gives you to the topic is amazing. If you want more details, you can look up on this one. So this is one slide introduction to uveitis. I understand most of the people listening today are general ophthalmologists. So I hope if they can carry the broad message from this slide, it will be very useful in the clinic. The first thing we do when a patient you are suspecting to have uveitis is to rule out a non-uveitis entity. This may sound very simple to everyone, but this is probably the first step where we make a mistake, and it's very, very common. The next thing we do is determining the primary focus of inflammation. Again, this may sound very simple, but this idea of anterior, intermediate, posterior, and pan-uveitis, which has come from the Sun classification system, is the most critical part of the next few steps, which I'm going to cover now. So if you think it's an anterior uveitis, the simple thing you do is look for mutton fat keratic precipitates. And if you find those mutton fat KPs, then you call it granulomatous. If you don't find mutton fat KPs and the patient has not been on treatment recently, then it's likely a non-granulomatous uveitis. There are clinical signs which will probably lead you to the diagnosis of a B27 type of uveitis, which is the most common cause of non-granulomatous uveitis. Of course, there are several other causes as well. If it is granulomatous, you are seeing keratic precipitates with a volume, then there are 3 patterns you should be looking for. The first pattern is that of TB or sarcoid, and you know the test to be done for that. The second pattern is that of a viral anterior uveitis. You know the increased intraocular pressure and the dispersion of pigment that is present in viral uveitis. The keratic precipitates are also pigmented, and the iris is atrophic, leading to loss of the pigment. So it's a lot of pigment going around. And the third pattern, which we often miss and is typically bilateral, is that of the chronic stage of Vogt-Koyanagi-Harada disease or even sympathetic ophthalmia. So this is broadly the 3 patterns of granulomatous anterior uveitis. In intermediate uveitis, the most critical part is to rule out what is not intermediate uveitis, and to do this, you should be looking for a yellow spot which is typically a toxoplasma retinochoroiditis at the back of the vitritis, of the headlight in fog. So at the back of the fog, you should look for the headlight, or you should be looking for a yellow patch in the periphery, which is typically acute retinal necrosis. Now remember, if the vitritis is so dense that the fundus has become hazy, then it is unlikely to be intermediate uveitis. It is more likely to be one of the causes of retinitis or retinochoroiditis. Now, intermediate uveitis, once you have reached a diagnosis, it typically doesn't have a very specific pattern. So this is one situation where you would want to do a screening, at least for TB, sarcoid, and syphilis in our scenario. But you may test for other conditions as well, depending on any other risk factor in that patient. For posterior uveitis, there are three things that we should be looking for. How deep is the lesion? That will tell you whether it's a retinitis or a choroiditis. Is there a specific pattern of the lesion? And the classical example is that of a serpiginous-like choroiditis. And the third thing is, what are the associated signs with the retinitis and choroiditis? And often you will be finding retinal vasculitis in those eyes. So together, it will lead you to four possible diagnoses: a retinitis, which is almost always an infection, and the diagnosis is almost always clinical, except for syphilis, where you need to test for TPHA. Retinal vasculitis is again a little bit like intermediate uveitis, because you have to do a bit of screening in these patients. Choroiditis is all about pattern recognition. Okay, there are ways by which you should be recognizing whether it's falling more into an infectious choroiditis or a non-infectious choroiditis, whether it is any particular pattern of non-infectious choroiditis like the so-called white dot syndromes, etc. So a lot of pattern comes into choroiditis. And the last one is posterior scleritis, where you have to look for the systemic disease, which could either be infectious or non-infectious. Of course, unlike choroiditis, posterior scleritis will be having the pain. The last pattern, the last anatomical location is panuveitis, and here there are three things to look for. One, what is the posterior component of the panuveitis? And suppose you're finding a retinitis or a retinal vasculitis or choroiditis, then you approach it like it is given above. If there is an exudative RD, that is the most common pattern of panuveitis we see in our clinics, then think of Vogt-Koyanagi-Harari disease, whether it's a acute or a sympathetic, and acute or chronic. And if there's a history of trauma or surgery, you think of sympathetic ophthalmia. Now, any case where you see an exudative RD, you should also be very careful in ruling out a non-inflammatory cause. And the best example for this is chronic or acute central serous chorioretinopathy, CSCR. There are many other causes of exudative RD as well. So make sure you have ruled out those non-inflammatory causes. So I hope, this slide is probably the smallest number of words in which you can represent all of uveitis, and it should be helpful to the general ophthalmologist in the clinic. I've taken out a lot of details which you will pick up as you start the practice. Now, the important thing is this line, the dashed line that I've put here, which shows that most of the diagnostic approach to uveitis is on the left side, and it's in the clinic with your slit lamp, your 90D, or your indirect ophthalmoscope. Most of it is happening on the left-hand side. It's only the small part which is on the right-hand side where you would need to do lab tests. So lab tests actually account for a very small portion of your uveitis practice. A much larger portion is how you speak to the patient and what you see in the patient. Okay. With this background, we will start. How do we investigate uveitis? As you have seen in the previous slide, most of the diagnoses are by pattern recognition, and this includes both infectious as well as non-infectious forms of uveitis. So the reason why we want to investigate uveitis is two things. One is either rule in or out an infection and rule in or out an associated systemic disease. Now, remembering these 2 points is very important when the patient asks you, have you found out a cause for my uveitis? We get a lot of patients from all across the country and abroad who come to us in search of a cause for their uveitis. So in those patients, we look for these 2 things. Is there any sign of infection? Is there any sign of a systemic disease? And if we are not able to find it, we clearly tell the patient that we have looked for what we could, and there doesn't seem to be one at this point of time. So we'll call it undifferentiated. And if we find another one in future, then we'll probably have a cause for your uveitis. So I hope we'll remember these 2 points in mind: infection and systemic disease. Now, when you start testing a patient, there are 2 questions you can ask. How good is your test? So for that, if the disease is present, will the test be positive? And if the test is positive, is the disease present? Now, if you think about it, it's the second question that is more important, right? Because the patient is not coming to you with the label of a disease. The patient is only coming to you with a test report. And you have to tell if the test is positive or negative, is the disease present or absent? And this concept is called as either positive or negative predictive value, while the above one, which is not important sitting in front of the patient, is the concept of sensitivity or specificity. Now, this positive predictive value is dependent on the pre-test probability of the disease, which is essentially the prevalence of the disease before you have ordered the test. And how do you decide this? Now, in any diagnosis, there could be 2 extremes, which is the diagnosis is impossible or it is 100% certain. But as you will know, it is usually somewhere in the middle, where it is either unlikely or likely, depending on what else you are finding in the patient. Is the disease you are suspecting very highly prevalent in the patient, in the area? What are the ocular signs you are looking at? What patient profile you have, and immune status, for the infections that you may find. On the other hand, a low prevalence of the disease, opposing ocular signs, a patient profile that is not fitting in, those will reduce the possibility of a given disease. So this is how you decide the pre-test probability of a disease. So this is one concept, one case where you will understand what I was just talking about. This was a patient who came to us with these retinitis lesions at the posterior pole, and the vision in the right eye had been poor for 2 months, while the left eye had just started deteriorating, which is when the patient came to us. Now you can clearly see that these are retinitis lesions, but it's not exactly fitting into a known pattern of retinitis. So we ran an OCT through the lesion, which shows that there is a bump in the choroid, which means it's a retinochoroiditis. And going by the recent OCT biomarkers for retinitis, this seemed very likely to be a toxoplasma retinochoroiditis. We also got the pictures from before, and it seemed that the right eye had this retinitis even 2 months ago. And, the OCT is also seen here. So based on this, we started the patient on treatment for toxoplasmosis. And we still, since this was a retinitis lesion, we asked for tests for syphilis and for HIV and asked the patient to come back in a week. Now you can see very clearly here that compared to what the brightness of the lesion that you saw a week ago, the lesions have now started resolving. The lesions are less bright. They also appear smaller in size. So the patient is responding to the toxoplasma treatment that has been started. However, you can also see that the patient tested positive for both TPHA and HIV. Now what do? The patient is responding to toxoplasma treatment, but the test for syphilis is positive, and you know that TPHA is a very good test. It has very high sensitivity and specificity for syphilis. So do you call it syphilis or do you call it toxoplasmosis. We decided to go by our clinical diagnosis and we continued the treatment for toxoplasmosis. In fact, we also added intravitreal clindamycin in this patient. And we decided to check for VDRL because in syphilis, TPHA once positive remains positive for the rest of life, whereas VDRL, though it has a low sensitivity, it is only positive at the time of active disease. Unfortunately for us, the VDRL also came out to be positive, and we were in a bit of a flux whether to start treatment for syphilis or not. Now, ideally in this situation, we should have done a CSF tap and looked at VDRL in the CSF. Unfortunately, the patient was not very willing, and in fact was not even willing to start treatment for syphilis and decided to come back after 2 weeks. The left eye, you can see when the patient came to us, had this peripheral retinitis lesion, which had also responded to the toxoplasma treatment. So I hope the concept of pre-test probability based on what kind of clinical signs you are seeing in the patient has now become apparent to you. Now, when you have a pre-test probability, how do you convert it into a post-test probability? For this, you need this concept of likelihood ratio, which is basically a combination of the sensitivity and the specificity of the test. And we have used this formula to calculate the likelihood ratio for the diagnosis of tuberculosis, ocular tuberculosis, for a positive quantiferon TB gold test, which was done in Bangalore by Dr. Kalpana Babu. Now, based on the findings of this study, we find that the likelihood ratio for quantiferon TB gold test for diagnosis of ocular TB is 3.42. Now, we put this number in a table which we call as the Fagan's nomogram, which obviously you are not carrying to your clinic, but I hope it will help you understand this concept of pre-test and post-test probability. Now, we put this red dot in the middle line, which is for the likelihood ratio, which symbolizes the number 3.42. Okay, and we now consider 3 possible clinical scenarios. The first scenario is of non-granulomatous anterior uveitis with a history of inflammatory back pain, very suggestive of B27. And somebody decided to test for quantiferon in this patient and found it positive. Now, does that mean that this patient has ocular tuberculosis? No, because if you connect the low pre-test probability at 2% on the left-hand column to the red dot, you see that it is leading to a post-test probability of only 10%. So for a post-test probability of 10%, you are probably not going to start this patient for anti-TB therapy. On the other hand, think of a patient with intermediate uveitis, but no history of TB contact and no testing for sarcoid or syphilis. This patient definitely has a higher pre-test probability, which is around 30%. But if you connect the dots, it is still leading to a post-test of only 60%. And this is also not very good enough to start this patient on anti-TB therapy. You would want to at least rule out TB and sarcoid, syphilis and sarcoid, and look for any other clues for tuberculosis before you start anti-TB therapy in this patient. Now let's look at the third scenario, which is of serpiginous-like choroiditis, which has been classically described in TB in India. And the patient also has a history of TB contact. Now here, the pre-test probability is very high, around 80%. And if you connect the dots, it is leading you to a post-test of 95%. Okay. Now this is very, very highly suggestive of tuberculosis, and this is a patient you are definitely going to start on anti-TB therapy. So I hope I could explain this concept here. Don't worry about the numbers. The numbers are only hypothetical. What I'm trying to say is that before you apply any test, a positive or a negative test, to a clinical condition, please keep the idea of pre-test probability and post-test probability in your mind. Now let's look at two very common tests that we advise to any patient of uveitis who comes to us. ANA or anti-nuclear antibodies and rheumatoid factor, which is done for rheumatoid arthritis. Now, if you look at the prevalence of either SLE or rheumatoid arthritis in any form of uveitis, it's actually less than 1%, be it anterior, posterior, panuveitis, anything. It's less than 1%. Now, with such a low prevalence of these two diseases in uveitis patients, even with a good sensitivity and specificity for ANA, the positive predictive value is less than 4% for ANA. And the positive predictive value for rheumatoid factor is, I'm meaning positive predictive value for rheumatoid arthritis is less than 2.5%. Now, how useful is this test? Even if you get a positive test and your positive predictive value is only less than 2.5%, how does it matter? Is it going to change your treatment for the patient? Probably no. Which means that a positive rheumatoid factor or ANA in any uveitis, provided there is no systemic evidence of either SLE or rheumatoid arthritis, has very little diagnostic value, and it's very high time that we stop testing for ANA or rheumatoid factor in our patients of uveitis who do not have a systemic evidence of the disease. I hope this message has gone out to everyone. The last thing I'm covering is the concept of uncertainty, which is the inverse of the predictive value. So this basically means that when the pre-test probability of a given condition is very low, then a positive diagnostic test would lead you to a false discovery. Okay, and we just covered that in the example of toxoplasma and positive TPHA, that the clinical case which I just showed you. Whereas if there is a very high pre-test probability and your diagnostic test is negative, then you have a high risk of false omission of your diagnosis. And I'll show you in the next example how this works. Now, this was a patient who came to us with bilateral choroidal lesions, and my colleague had tested this patient for a Montu test, which is TST or tuberculin skin test, and a CCT thorax, and both of these were negative. There's no history of TB contact at that time. So my colleague decided to treat this patient with corticosteroids, and you can see that the lesions have responded so nicely. Okay, but the patient comes to us the next year with this large lesion that you're seeing here, and this is when the patient told that he was actually a migrant worker, which we know is a very high risk for tuberculosis. This is the time when we started this patient on treatment with anti-TB therapy alone, and this is what we found. In 2 weeks, the lesion has melted away significantly, and in 5 weeks, it's almost gone with anti-TB therapy alone. Okay, so even with negative tests, the patient was responding so well to anti-TB therapy, and this is an example of false omission that I just mentioned. The last thing is, when do we screen for uveitis? So this should be done only if the diagnosis you are looking for can present with any form of uveitis. It needs lab tests, and the test is very good. It has high sensitivity and specificity. Now, there are only two conditions that fit into these criteria. These are sarcoid and syphilis. These are probably the only two tests that you can do in almost, I say almost all forms of uveitis. There's nothing else that is required in all forms of uveitis, including your Montu test. So the summary is that the patient is way more important than the test. The positive and negative predictive values are more important than the sensitivity or specificity. We understood the concept of pre-test probability based on the history, the clinical signs, and the prevalence of the disease. And when the pre-test probability is very high or very low, there is a chance of false discovery or false omission of a particular diagnosis. Thank you for your attention. There is no role of the screening of workup. Thank you.
A nice talk. Also, I'm Rajesh here.
Yes, Rajesh, nice to see you.
So it's always nice to listen to you. And this definitely has been a learning experience for most of us, because UVT is probably one condition where we bombard the patient with a lot of investigations. And especially in this era of multimodal imaging, you sometimes feel that you have not done justice to the patient if you have not tested the patient with every investigation that is available. So probably this is an eye-opener for most of us, that we can actually limit our investigations to what you expect in that patient. So it is basically understanding of the pattern of the disease, understanding of the disease that actually decides what investigation has to be ordered for that particular patient. That is the summary of the talk. That is what I understand from this talk.
Right.
So don't you do, because now you look at the literature, you can see that there is multimodal imaging for every uveitis conditions. So do you actually order almost all these investigations? Because working in an institute like LVP, you have the privilege of ordering the patient for all these investigations. And do you actually do all these sort of investigations, starting from the fluorescent angiography to OCT angio for these patients with choroiditis?
You know, we should be very clear with the purpose of the investigation. Okay, so usually at presentation, the purpose of the investigation is twofold. One is recognizing the pattern of the disease, and the pattern may not always be evident on clinical evaluation. A good example is serpiginous-like choroiditis, and you know, the pattern may not be very obvious when you're clinically examining the patient, but the autofluorescence will clearly demarcate the outlines of the lesion and tell you the pattern. So one is pattern, the second is extent. And a good example of the extent of the disease is the toxoplasma retinochoroiditis OCT that I showed you. You know, the retinitis lesion was not very classical of toxoplasma, not that it was impossible, but not very classical. So the OCT there with the choroidal involvement showed us that, you know, this could be toxoplasma. So pattern recognition and extent are the two primary purposes of imaging, and whichever is required at whatever time for whatever condition we are looking at, we should definitely do that. Once you have started the treatment, you have to also do imaging for the follow-up and looking at the response to treatment. So that's the third purpose of looking at images.
Can you show that slide where the initially TB was diagnosed? Can you please explain that pattern for the benefit of the audience? The pattern, the lesion pattern, whether you would have suspected tuberculosis in the first instance if you had seen that patient.
This one, this patient?
Yes, this one, the first time when the patient presented.
Yeah,
I think
so this was June 2018 when the patient came to us. You see that the lesion is primarily choroidal. Okay, you can see the lesions moving over it. There are scars around, but you know, someone might say that you see activity at the margin of a scar in toxoplasma. But you can see that the lesion is essentially a choroidal lesion. The vessels moving over it are very, very clear. Okay, so toxoplasma is a retinitis lesion. So that distinction between retinitis and choroiditis is very, very important. So what all lesions, and also you can see that the margins of the lesion are irregular. Now, when you see a, you know, unlike retinitis, which is more likely to be infection, in choroiditis, you have an equally strong possibility of that being a non-infectious condition. So how do you make out that your choroiditis lesion is infectious or non-infectious? Now, some of the clues for infection are the paucifocality, okay, just one or two lesions. Non-infectious choroiditis is typically multifocal. The lesions are deeper and the lesions are very well rounded. Okay. On the other hand, the lesion that you're seeing here is paucifocal. There is just one in each eye, and the margins are irregular. And if you run an OCT through this one, we don't have the OCT, of course. You would have also noted that there is an involvement of the retina. There is a chorioretinitis in this patient. Now, when the disease moves into different layers from the choroid to the retina or choroid to the sclera, you should strongly suspect an infection. So these are the clues that would have told you that you are probably dealing with an infection. If this patient comes to me today, I would have definitely got a quantiferon test done. Now, quantiferon should be done not because it is a very significantly better test than a MON2 test, but there are patients where you can have a MON2 negative and the quantiferon positivity will lead you to the correct diagnosis. I would have followed up this patient very closely, and with these hints of infection, I would have tried to rule out other causes of the infection. In this case, fungal choroiditis would have been the number one DD, which is Aspergillus mainly. And the second DD, which is a little far-fetched, could still be syphilis and sarcoidosis. And I would have tested this patient for syphilis and sarcoidosis. But fungal is the one which still had a strong possibility in this patient. Okay. Did that make sense, Rajesh?
Yes, definitely. I would like to ask you one more question, because this is one very common scenario that we see. Patient presenting with intermediate uveitis. You test the patient, you don't have any patches of retinitis, choroiditis, or vasculitis, just intermediate uveitis, and you test the patient comes back with a positive mantle. Do you think that that patient requires treatment with ATT?
No. So I showed that. Sorry, I'll just go to that image that I had for the Fagan's nomogram. Okay, and that the second clinical scenario that I covered here. Okay, this one. So this tells you that with no history of TB contact, and there are certain other hints of TB intermediate uveitis, you will see, peripheral choroidal lesions, either active or scarred. So I am very finicky about getting a thorough history of TB contact. It's not like, did you have TB? Did someone in your family have TB? No. My history taking is a little more detailed. I will check the occupation of the patient. Sometimes the patient turns out to be a nurse, an ASHA worker. And remember, ASHA workers are the ones who go to deliver the TB medicines to patients. So, migrant worker, the best example we find a migrant worker. Remember, for a migrant worker living in a small room in which 3-4 people live, no other person will tell that I have got TB, because if that person tells, they will be thrown out of that room. Okay, which becomes a very difficult situation. So the moment they tell migrant worker, the suspicion of TB becomes very, very high. So we have to take that thorough history with that. And only when I get these additional clues for TB, I suspect TB in that patient. Conversely, there are clues which are against TB. And one example is, of multiple sclerosis. Okay, so multiple sclerosis is relatively rare in our population, but it still exists. And if you get history of tingling numbness, okay, paresthesia, which are suggestive of multiple sclerosis, if you see retinal vasculitis above the horizontal midline. Now, retinal vasculitis is commonly seen in patients with peripheral retinal vasculitis, okay, in patients with different forms of intermediate uveitis, TB, sarcoid, etc. But if you see retinal vasculitis above the horizontal midline, that's a strong suspicion of multiple sclerosis. So clues against TB are not present, clues favoring TB are present, then I would probably start these patients for anti-TB therapy.
Sir, in both your cases, you have not given steroids. Your infection, either in your toxo and neither in your tuberculosis patient.
Yeah.
What could be the reason?
So there are different reasons for the two cases. One is the toxo patient that came to us. Okay, this one we were not sure. This is looking back, we can see the scar in the center and the retinitis around it. But you see, suppose this was toxo, you would have expected, in an immune competent patient, you would have expected more vitritis in this patient, which was not seen. Okay, so there's something that was missing, and in such a unclear picture, I won't jump into. I knew this was a retinitis lesion, okay, which means this is likely an infection. Remember that Behçet's is the only non-infectious cause of retinitis. So this was not Behçet's, obviously. So this was likely an infection, and I'm not sure what infection it is because it's not fitting into a known pattern. But the pre-test probability is highest for toxoplasmosis based on the clinical picture and the OCT that is seen in this patient. So I just started on oral cotrimoxazole and I called for an early follow-up. Now it is 1 week here, but even better would have been a 3-day follow-up in this patient. So the reason I didn't give steroids here is because, I was not sure what infection we are dealing with. And like you saw, the TPHA came positive, and indeed it was a difficult case to diagnose.
Why didn't you consider an PCR test here?
No, I think, PCR didn't have much of a role here for 2 reasons.
Toxo.
Yeah, it is only available for toxo. And remember that in toxo, PCR is positive only in the earliest stage of the disease. If you look at literature coming from Germany and France, almost 10, 15 years old, what really works if you have a doubt of toxo diagnosis is the Goldman-Whitmer coefficient, which unfortunately we don't do in our clinical practice. These kind of cases, the Goldman-Whitmer is the one that works better, chronic toxo. PCR works only in the acute stages of toxo. Okay. The second reason is you don't see much of vitritis. Now, without much vitritis being there, the PCR test coming positive is very, very low. This works for toxo, this works for TB. Okay. If you don't have the inflammatory cells, the chances of getting your PCR positive is very low. Okay. Now, the answer to your earlier question, why didn't I use steroids for the second case, which was, where I suspected TB, is that this was a large granuloma. And, again, we were not sure what diagnosis we were dealing with, but there was a strong suspicion with such a large granuloma with surrounding exudative RD, strong suspicion of an infection. Okay. Now, typically, these are the types of ocular tuberculosis that are multibacillary. Okay. We do not have very clear evidence from our literature, but if you look at the literature that has been published from the US, these are the lesions where you will see a lot of bacteria. And at least in the early stages, I would prefer treating with anti-TB therapy alone and then looking at the response. I could have also called this patient at 1 week, looked at the response, and then thought of adding steroids or not adding steroids. Slightly different reason, which we have covered in a paper which we published 2 years ago, is that some patients, and this may not apply to all patients, in some populations respond very well to anti-TB therapy alone. And we have seen this when I was practicing in Odisha for almost 14 years. So patients there will respond to anti-TB therapy very well, whereas now I'm in Hyderabad for last 3 years. And, we have to give a lot more steroids here in Hyderabad than what I required in Odisha. I think this has to do with the genetic background of the patient also. So there is no hard and fast rule about when you should give steroids or when you should not give steroids. But the big picture is that if there is a strong suspicion of infection and you're not sure what infection you're dealing with, start the antibiotic therapy and call for an early follow-up and then decide whether to give steroids or not. Okay.
I think we can move on to the next talk.
Yes,
and can
thank
have
you very
more
much.
discussions towards the end of the session.
Thank you, sir. Thank you so much.
Yeah,
Now we move on to infectious uveitis, and let's learn from Dr. Risha how she is taming the bugs. Dr. Risha is a retina and uveitis consultant at Little Flower Eye Hospital, Angamali. She has done her uveitis training from Shankar Netralaya, Chennai. Over to Risha.
Yes. Thank you, Rajeshri. Thank you, Dr. Rajesh. After the exhaustive session on diagnosis of uveitis, we'll be moving on to the management of uveitis, and I'll be talking about the infectious uveitis management. Why it is important? Because infection remains the common cause of uveitis, at least in our country, and prompt diagnosis is very critical so that appropriate antibiotic therapy can be started. And considering an immune pathology and starting immunosuppressive therapy can exacerbate an underlying infection, leading to blindness and rarely even death. The major objectives of the therapy of uveitis is alleviate the symptoms and signs like redness, photophobia by giving topical steroids and cycloplegic agents, control the infectious process by giving the correct antibiotic treatment, prevent damage by inflammatory process by adding steroids, and prevent recurrences by giving the proper maintenance dose, and rehabilitation of vision by treating the complications associated. The two parts of treatment include treat the acute disease process and manage the sequelae and complications of uveitis like cataract, glaucoma, and CNVM. We will start with the commonest one, toxoplasmosis. It can present as a primary retinochoroiditis lesion with vasculitis, or a small reactivation with vasculitis, or a clear-cut reactivation lesion, or a neuroretinitis-like picture. The drugs for toxo include the classic therapy described as pyrimethamine and sulfadiazine along with corticosteroids. We are not using this nowadays because it's not easily available. The drugs commonly used are trimethoprim and sulfamethoxazole combination along with systemic steroids start by after 3 days of antibiotic therapy. The second option is clindamycin, especially in sulfa-allergic patients. Atovaquone is not available in our country, and azithromycin theoretically has a superior role against cysts and bradysoids. So it can be added along with Bactrim DS or clindamycin so that theoretically it can prevent the recurrences. Intravitreal injection of Clinda and Dexa is a good option, which has more convenience, better bioavailability, and fewer follow-up visits needed and fewer hematological evaluation needed. It can be considered alone or along with the systemic treatment, especially if the systemic treatment is contraindicated. In pregnancy, intravitreal injection of Clinda and Dexa or spiramycin is the drug of choice. Long-term treatment, long-term intermittent prophylaxis with Bactrim DS is indicated, especially in an immunocompromised patient. These are details about the drugs used for toxo treatment and the dose and the side effects. Before starting sulfa drug, ask about sulfa allergy. And while treating Clinda, warn the patient about pseudomembranous colitis signs. And as an example of toxo headlighting the fog appearance after treatment with the Bactrim DS, along with steroids for 6 weeks, the lesion is found to be completely healed. Another macula-threatening lesion treated with the intravitreal Clinda and Dexa, and the lesion completely healed, and we could save the vision. The next common cause of infectious uveitis is ARN. The characteristic triad is moderate to severe vitritis, severe vasculitis, and peripheral confluent retinal necrosis, which needs immediate treatment, and the treatment options are IV acyclovir for 5 to 10 days, followed by oral acyclovir 800 milligram orally for up to 3 months. Oral valsivir has an almost equal bioavailability, 1 gram TID orally for same duration. Valganciclovir is another option, 900 milligram BD for 3 weeks for induction and OD for maintenance dose. In sight-threatening retinitis, or if systemic treatment is contraindicated, ganciclovir intravitreal treatment can be considered, and the dose is 2 milligram in 0.1 ml. Should be treated with oral steroids along with, and to be started 24 to 48 hours after the antiviral therapy. The role of antiplatelet therapy is unknown. Prophylactic laser has a controversial effect on the management of ARN, and the best one is early vitrectomy. This is a case of early ARN treated complete and lesion almost completely healed with Valsivir oral. Yet another patient of ARN treated successfully with oral IV and oral aceclidine. Another infectious cause for retinitis is CMV, and usually associated with HIV. So heart has a major role in the management. And for CMV, IV ganciclovir for 2 weeks and then maintenance dose, or valganciclovir 900 milligram BD for 2 weeks and then orally for maintenance. Intravitreal ganciclovir 2 milligram twice weekly for 3 weeks and then weekly for maintenance dose. These are the common drugs used for CMV retinitis. Yes, the other major cause for infectious uveitis is TB. As mentioned earlier, it can have protein manifestations like TB granuloma, TB choroiditis, TB choroidal abscess, neuroretinitis, or a serpiginous choroiditis like picture, or it can even have a posterior scleritis like manifestation. Anti-TB treatment, anti-tubercular therapy for 6 to 9 months is the treatment of choice. And the induction is Charcedi for 2 months and then HRE. Steroids can reverse the hypersensitivity response to TB treatment. Well, this 17-year-old girl who had a biopsy-proven abdominal TB presented with retinal vasculitis, treated well with the ATT and steroid. This was a case of TB choroiditis treated only with the ATT without the steroids, because steroids were contraindicated in this patient. Even without steroids, it resolved completely. And always think about combined infections like TB co-infection with CMV in this HIV patient who needs treatment for both. Yet another uncommon case of posterior uveitis is syphilitic chorioretinitis. Here the picture is a typical ground glass picture of chorioretinitis, and drug of choice is crystalline penicillin IV for 10 to 14 days. And the alternate drugs are azithromycin, doxy, and ceftriaxone. Here also the role of steroid is not clearly known. It's a case of acute syphilitic posterior placoid chorioretinopathy treated with antibiotic and steroid therapy, and the lesion melted immediately after the antibiotic treatment. HIV can have various eye infections depending upon the CD4 count, and each should be treated along with heart with appropriate antibiotic. Now we will come across with some rare posterior uveitis due to infections. Like cysticercosis, the diagnosis is mainly clinical, and the treatment is surgical removal of the parasite from the eye. Post-fever retinitis, always identify the cause for the fever and treat accordingly along with systemic steroids to reduce the ocular inflammation. It's a case of DUSN, identify the worm and laser it. If you are not able to identify the worm or laser it properly, albendazole for 100 milligram OD for at least 1 month along with systemic steroids. Toxocara, if there is active inflammation, treat with steroids and antihelminthics, and surgery is indicated if there is fractional or combined RD. And another cause for posterior uveitis, infectious causes, P. acne, endophthalmitis. The treatment is vancomycin, intravitreal and into the bag, or vitrectomy with the posterior capsulectomy. Last but not the least, an endogenous endophthalmitis. Identify the bug, identify the cause of systemic infection, and treat with the correct antibiotic therapy and surgery, vitrectomy if indicated. And always look for the complications associated and treat it accordingly. Like neovascularization in a case of occlusive vasculitis, treat with sectoral PRP, and non-resolving vitreous hemorrhage or vitreous floaters, persistent vitreous floaters, do vitrectomy, and cataract surgery if there is secondary cataract, and glaucoma, either medically or surgically treat. For example, this was a post-viral vasculitis with NBD and NVE treated well with PRP, and a toxoscar with secondary CNVM treated well with antivitreal anti-VEGF therapy. And most important thing to be keep in mind is if inflammation is not responding as anticipated to your steroids or other immunomodulatory therapy, please ensure again and again that an infectious cause has not been missed. Thank you.
Thanks, Risha, for that wonderful presentation. Actually, maybe the last slide is probably the most important slide in your presentation, because we see large number of patients with the choroiditis being, or anything white on the retina being treated only with steroids. So the moment you see that the lesion is not responding to a steroid treatment alone, then you should probably think about changing your diagnosis. Now consider the infectious cause. That is the main take-home message. But then again, the pattern of the lesion always gives an idea about most of the time the causative agent that you're dealing. So toxoplasma, as Basu also showed, so it's a lesion which is involving the entire retina. It can also involve the choroid. So when the choroid as well as the retina is involved, then you think about toxoplasma. When it is predominantly limited to the retina, you're thinking mostly in terms of a viral retinitis. And probably seborrheic retinitis is also something that we are seeing very commonly these days. You had shown a nice picture of seborrheic retinitis, which has got this kind of a confluent retinitis patch. Along with that, you can see those punctate deposits on the surface of the retina. That is a very characteristic of seborrheic retinitis, because I learned it from one of my patients. Because that was in a patient who was already on treatment for HIV. The patient came with a retinitis, no history of HIV, but on evaluation, I found that he was having HIV. So on HIV, when you see a retinitis, you think about, first thing that you think about, or something that is ingrained in your mind, is that you see retinitis. So I was probably thinking in terms of seeing retinitis, started the treatment. But this was having this kind of picture, that the picture that you're shown there. Can you show that picture one more time for the benefit of the audience? And that was the picture there. But anyway, I thought that I will start the treatment for a CMV retinitis. And then in the meantime, all the investigations came, the results came, and the patient was TPHA positive.
Risha will take this. No, sorry. Go ahead.
Of course, the clinical picture is the most important one. The classic headlight in the fog appearance for toxo, or a previous scar, previous toxo scar associated. For toxo, these two, ARN, the typical characteristic picture, the mode of spread, and vasculitis associated. And for syphilis, again, more of like choroidal involvement than a retina. It will be more like a chorioretinitis than retinochoroiditis in a toxo lesion. And of course, investigations like imaging, like OCT, helps in some cases to identify the retina involvement or choroidal involvement, and along with blood investigations.
Yeah.
Also, anything to add?
Yeah, just if I may add, anytime you see a bright white lesion which is fuzzy and the vessels are disappearing into it, it's a retinitis, and a retinitis by definition is an infection. So we, should follow what Risha just described about the ways you identify the infectious retinitis. The only non-infectious cause of retinitis is Behçet's disease. And, the ways we ask for oral and gentle ulcers to make the diagnosis of Behçet. The eye is typically white. You may have a mobile hypopyon in that eye. So those are the ways you diagnose Behçet. But otherwise, retinitis is infection, and you must do everything to find out the pattern of infection. Now, remember, in all the causes that she mentioned, the only place where you really need a blood test is syphilis. Okay. All others are diagnosed based on the pattern, and you should be able to recognize the pattern and start the treatment.
And one more point, if the lesion is unilateral, think more of infection.
Thank you. As we are running out of time, we move on with the last talk of the session. We go on to non-infectious uveitis. I welcome Dr. Natasha, who is a professor and a retina consultant at Amrita Institute of Medical Sciences. She has a keen interest in ROP and uveitis. She will be talking on managing the pugless.
Good evening to all. It's wonderful to be here tonight at this webinar, and I thank the organizers for giving me this opportunity. Let us go on to seeing how we can manage non-infectious uveitis. We know that uveitis can be divided based on the etiology into infective, non-infective. So we will talk about non-infective uveitis. And it is mostly an immune-mediated process, and it may be related to a systemic rheumatological disease, or it may be a solitary ocular disease. It is an important cause of visual morbidity in adults and in children. But in our population, we should never jump into the conclusion of non-infectious uveitis, because we must always rule out infections, and we will see how we can do that as we go ahead. Let me talk about a few of the common non-infectious uveitis: the HLA-B27 associated uveitis, the Fuchs uveitis, sarcoidosis, Behçet, multifocal choroiditis, serpiginous choroiditis, and the more commonly seen VKH disease. Since it is not possible to talk about the manifestations of all of them, I have just put very few slides on actual clinical manifestations and mostly general guidelines on how to manage non-infectious uveitis. So ankylosing spondylitis associated uveitis, more commonly in males, usually above the age of 8 years, an acute recurrent uveitis that is bilateral and symmetric. And unlike the JIA associated uveitis, here it is usually a severe acute symptomatic anterior uveitis and often presenting with a hypopion in the anterior chamber. Inflammatory bowel disease associated as in Crohn's and ulcerative colitis is also again a severe and symptomatic uveitis, acute anterior uveitis and sometimes episcleritis as well. In sarcoidosis, the most common presentation is an anterior uveitis that is granulomatous with granulomatous KPs, iris nodules, and broad-based posterior synechiae, and can also have complications like band-shaped keratopathy, cataracts, and glaucoma. Inflammation of the posterior segment is usually in the form of retinal vasculitis and sometimes multifocal choroiditis also. And the vasculitis, as we all know, has a typical candle wax drippings and the periphlebitis predominantly. Serum A, serum calcium, and can give us the clue from serology, and MAN2 will be negative. Hilar lymphadenopathy on an HRCT, and final diagnosis can be made by a lymph node biopsy or a bronchoalveolar FNAC bar lavage. Behçet's, we have already covered it when we were discussing the infectious uveitis. It is the only one that has retinitis, retinal infiltrates. Hypopion uveitis, it can cause arterial and venous vasculitis. And finally, it causes a diffuse chorioretinal atrophic changes. SLE can present with mild anterior uveitis. It can present with a pan uveitis, and most characteristically, especially in the APLA positive people, they end up with an occlusive vasculitis that is very difficult to manage because it causes severe and devastating loss of vision. The ANA profile and the APLA will be should be checked, and most of these patients will need a rheumatology consultation and treatment along with that. One of the conditions that we ophthalmologists most often manage by ourselves is Ward Koinagi-Haradas. It is a bilateral granulomatous pan uveitis with preceding neurological symptoms like headache, neck stiffness, and tinnitus, late onset skin changes like vitiligo and perioral depigmentation. In the fundus, there will be a mild vitritis with exudative retinal detachments and disc edema often. The FFA is very characteristic with very pinpoint leaks that then coalesce to form large sensory neural detachments. Later on, after treatment, it gives the typical sunset glow fundus because of the depigmentation. Differential diagnosis includes multifocal CSR, TB, exudative detachments, posterior scleritis, and sympathetic ophthalmia. This is a typical VKH case presented with bilateral blurring of vision with anterior segment inflammation, and in the fundus disc edema and multiple sensory neural detachments. And the OCT also showed the sensory neural detachments. The FFA showed the disc leak and the pinpoint leaks. And she was managed with both systemic steroids as well as MMF. And at 1 month follow-up, she has resolved well. The fluid has gone down. At 2 months, it is completely resolved. And so this just shows the transition with successful management. You can see that there was not much depigmentation either. On the other hand, this is a 40-year-old lady who presented with very typical VKH-like signs with, again, sensory neural detachments, disc edema, bilateral. We started her on immunosuppression, and but 3 weeks into that, she came back with this severe orbital cellulitis and new lesions in the fundus and what looked like tuberculosis choroidal lesions. And she turned out to be MAN2 strongly positive. And after sending a PCR, she was TB positive for PCR in the aqueous as well. So this is just to tell you that sometimes the typical picture in our country may be that of something that is non-infectious, but especially when you're thinking of putting the patient on long-term immunosuppression, it is worth a while to just rule out TB before we start long-term immunosuppression and high-dose steroids. So the approach to non-infectious uveitis should be a thorough clinical evaluation and systemic review, because many of these patients will have some systemic symptoms that tell us that we are not dealing with just an eye infection alone. And the diagnostic workup should be systemic baseline workup, and along with that, rule out infective pathology. And in your clinical examination, if you have whatever clinical doubts you have, you check the lab markers for that. Your multimodal imaging can also give a clue, especially in conditions like VKH, to what we are dealing with. This is the lab investigations that have been told. Minimal routine workup is step 1. And in step 2, you should go on to the ones that are indicated by your examination. And step 3 should be the more extensive, literally desperate attempt to find out if you do not get anything in step 1 and step 2. The treatment algorithm includes, of course, local and systemic therapy. The first idea is to control the active inflammation, for which our most important tool will be systemic steroids. And however, we need long-term immunosuppression to avoid recurrences and relapses. And we also need to manage the associated ocular sequelae. So steroids hit hard, hit fast should be the dictum. And once you are expecting a chronic or long-lasting disease process, you should use steroid-sparing immunotherapy, especially if you cannot control inflammation with less than 7.5 milligram of prednisolone or equivalent, even after 2 to 3 months. The choice of immunosuppressive agent varies from disease to disease. The antimetabolites that we have are azathioprine, methotrexate, and MMF. There are no head-to-head RCTs for safety or efficacies, and not one agent is favored over the other, and most have similar efficacy and adverse effect profiles. Now, in children, methotrexate is the initial choice in children, and in adult patients between MMF and methotrexate, there was no significant difference. Role of biologicals, we all know that adalimumab is now approved for non-infective intermediate and posterior and pan-uveitis in adults and in children. However, antimetabolites, we still continue as the first-line agent, and then when they are not responding in our country, especially because of the cost factor. Local steroid therapy, topical, of course, are needed for anterior uveitis and pan-uveitis. Intravitreal sustained release implant and posterior subtenon can be considered in complications like CME, in unilateral presentations, in those who cannot be put on systemic steroids. Intravitreal dexamethasone implant can be, of course, removed with vitrectomy if we need to reverse it, especially if you have hit upon something, the infection that has not been previously recognized. Posterior subtenon is more tricky because then removal is very difficult and reversal is difficult. If there is poor response to immunosuppressive therapy, like Risha mentioned earlier, we should reconsider the diagnosis and rule out masquerade, especially in elderly patients. Treat the ocular sequelae, you may need cataract surgery, BSK removal, especially in the children, and anti-VEGF injections sometimes, and pan-retinal photocoagulation if there is neovascularization due to occlusive vasculitis. Some cases with vitreous hemorrhage non-resolving will require vitrectomy as well. And this is just a small case to say that you have to keep a keen eye for sequelae. She was a diagnosed case of VKH on immunosuppressants, and a very regular follow-up, came with blurring of vision in one eye and had a small PED-like lesion at the fovea and what looked like a small amount of fluid as well. But there was no evidence of any inflammation, and there's a small hemorrhage at the site of the lesion. And it was a case of a choroidal neovascular membrane that has come in a treated case of VKH. Post anti-VEGF injection, she resolved well and came back to 6/9 vision. So in my take-home points, rule out infectious causes prior to systemic or long-acting local immunosuppression. Close monitoring of response to treatment, and do not be afraid to reassess and rule out infections again if it is not giving you the response that it should. Long-term systemic immunosuppression will be required in most of these conditions. Newer agents should be considered when you have recalcitrant cases, and you need to manage these cases in close association with a rheumatologist. Thank you very much for your patient hearing.
Rajesh, you're muted. Rajesh is muted.
Yes. Okay, nice talk, Natasha. So, one important take-home message is that you have to treat these patients with steroids for a long time. Especially if you have ruled out infection, then these patients are going to take, most of the patients are going to require treatment for a very long time. And what is often seen is that patients are started on steroids, they undergo rapid taper, and everything is stopped in a matter of 1 month, and the patient comes back with the recurrence. So you should always understand that these patients will require steroids, as well as when the steroids have to be given for a long duration, always supplemented with immunosuppressives. Even biologics when it is ready. So you can always take the help of a rheumatologist when you are starting the treatment for a non-infectious uveitis. So that is the most important thing, because this is very commonly seen. Even when you start topical steroids for anterior uveitis, many a times the patients are given tapering doses of steroids 5 days each, and then they come back after a few weeks with a recurrence of inflammation. So, so when you're treating non-infectious, always be prepared to treat them for a long time.
What we commonly see is an inadequate dose, and it is tapered too fast. That is the common scene, and it really can mess up the picture as well. When we give steroids, we give 30 milligram, 20 milligram, and then send the patient off, and then taper over 3 days, 5 days. So that should be avoided as far as possible.
One comment about the retinitis in Behçet's disease, because Vasu has been telling right from the beginning that maybe Behçet's is the only non-infectious cause of retinitis. And I would like to tell you about one of my experience. I saw a patient who was having retinitis involving one eye, and I could see a patch of retinitis also. So I thought that the first diagnosis in our scenario is toxoplasma. So I started treating the patient with toxoplasma, gave steroids, everything disappeared. After a few days, he came back with another crop of retinitis. So what is important to understand, so I was not sure about the diagnosis. The patient was about to leave me, and then suddenly I remembered the discussion that I had with one of my very close friends, who's also a UV expert, Dr. Prakash. So one thing that he had told me was that if you see fleeting retinitis, one thing that you should think about is Behçet's disease. So immediately I got the HLA-B5 done, and he came positive HLA-B5. He was having a Behçet's disease. So in Behçet's disease, the kind of retinitis that you see is often a fleeting retinitis. It usually heals without leaving any scar. So if you see a retinitis which is fleeting, it's not it is not leaving behind any scar, then always think about Behçet's as one of the important causes. Then about the weak edge is probably one of the most common non-infectious uveitis that we confuse with a very common condition called CSR. So Natasha has already shown you all the investigations done, but I think if you look at the OCT itself gives you a lot of a good idea about that that is not actually CSR, especially if you see those lumpy bumpy choroids, and lumpy bumpy choroids along with the compartmentalization of the fluid in the subretinal space. That is something called a bacillary detachment, and that if you see that, then in all probability you are dealing with weak edge. I think both those slides were shown by Natasha, that the patient was having this lumpy choroids, and also another slide showed this bacillary detachment.
So thank you. All good things have to come to an end. The last 4 hours have been thoroughly enriching and enlightening. And all my colleagues from KSOS, as well as my friends from across India, Soumya, Prashant, Sharavanan, and Abhishek, all have done a wonderful job. Starting from Praveen Murali at 5 o'clock to Natasha at 9 o'clock, I've not missed a single minute of this scientific and academic feast. Thank you very much. And now it's over to Dr. Thomas Arun Varghese from Cochin Ophthalmic Club for the concluding remarks.
Thank you very much. Big thanks to Dr. Thomas Cherian. When KSOS told me to have a Retina webinar with COC, I straight away called Dr. Thomas, and he just took over and arranged all the faculty. I'd like to thank him, especially big thanks to him for arranging everything. And one thing I told him is definitely we want to talk about Dr. Soumya Basu, because I heard your talk in Ignite and it was just awesome. So I said, that's definitely, it would be great if you can get Dr. Soumya for a talk. So thank you all very much. Thanking all the speakers, Dr. KSOS and COC faculty, Dr. Praveer, Dr. Prakash, Dr. Rajesh, Dr. Rajashree, Rahul, Divya, chairman and moderators, Dr. Girdhar Sir, Dr. Sheena, Shane, Dr. Sindhu, Dr. Risha, Natasha, Dr. Mahesh, Dr. Gopal, and Dr. Prakash. So thank you all very much. And we had a very good viewership, around 100 plus viewership as well, like changing at different times. And I personally have taken a lot of lessons from this. And thank you all for being with us today and enriching our experience. Thank you.
Thank you.
Thank you, sir. Thank you.
Thank you.